Um, Good afternoon, colleagues. I hope we have rounded off to the afternoon. It gives me great joy to see each one of you here. I want to welcome in a special way our president of the association, Dr. Musana Othiniel, and the executive director of AOGU, Professor Dan Kaye. Thank you for visiting the region. This is the first time it is happening when it is purely organized as a meeting of gynecologists and gynecology residents who are associate members of the association. So it gives me great joy to see when my colleagues who have come from a bit far, Dr. Banya and Dr. Semuju. Thank you very much for showing this solidarity. I have seen the Dean walking in. Dr. Ngonzi, you're also very welcome. And without taking a lot of time, I would like to take this opportunity to welcome Dr. Kayondo Musa, the head of Department of Obstetrics and Gynecology at MAST, but who is also the immediate first vice president of AOGU, to come and open for us the meeting officially.
Thank you, Rogers. AOGU President, Dr. Musana. Our CEO, Professor Dan Kaye. The Dean Medical School, Dr. Ngonzi. AOGU Western Chapter, I'll call you not representative, AOGU Western Chapter President, Dr. Rogers Kajiwangu. The Uganda Medical Association Western Chapter, Dr. Waraganise. The specialists here present, AOGU associate members, those are the residents, and their associates, the international students, residents, and all colleagues and sponsors. You are welcome to Mbarara. We are really glad that our Western Chapter, and really want to thank Dr. Rogers for making this association vibrant. And I think this is the first chapter in all the regions that is hosting such a meeting. Really want to thank you. It's very good that now we have brought us. I last saw Semuju, I think six years ago, is now here. I don't know, where is the medical superintendent of GCs? He's coming. He's a big man now, he can come later. So, I don't want to take much time, but I want to really thank the Secretariat, AOGU Secretary, the President and CEO for really supporting the AOGU Western Chapter in so many ways. The residents who are now the associates. It's not by default that when you're a resident you're an associate member. No. You have to pay money, please. Please, we have our president now. You don't have to move to Kampala or mobile money or whatever. And you know he's the head of later. All the money will go straight to our secretariat in Kampala. There are so many benefits of you being a member, an associate member, then finally become a member after graduation. So many. Some of us, me and the dean here, I think became associate members. Me, I became an associate member, fully paid associate member in 2007 when I had just joined my postgraduate. And I've I went through until right now when I'm a member and immediate past president. So there are so many benefits. One, AUGU has supported our department. And you know, the Department of Obstetrics and Gynecology is the mother department of AUGU because we are the ones who supply AUGU with members. So we are really glad for them helping us. They have supported. Some of you have attended the trainings. Sister Chan, you crossed the road until you reached Speak Hotel. Yeah, so you have attended these AUGU trainings, and they only give us these trainings because we know we are producing very good people who are going to join the association. So it's important that we become fully paid associate members. Some of people have had their postgraduate research, which have been supported by AUGU. Yes, if I don't forget, I know there was Okelo, not Maxwell, James, or Araganise here. Yeah? So AUGU is a very, very, very strong and big pillar to our department. So I really urge you to really support the AUGU. AUGU can only stand through our contributions. So we really want you to support, and we want to show that Western Uganda that we really support this association. So I want to thank you so much for coming. I won't say so much. I want to thank our members not from the department, who have come from different areas of this Western, not Southwestern, because this Western chapter has both Southwestern and the Western part. That's the Hoima and the Bunyoro region. It's both Bunyoro and Ankole all combined. So that's so thank you so much, and we hope we are going to have a very good deliberations in this meeting. Thank you.
Thank you very much, Dr. Musa Kayondo, for those wonderful remarks. I think we will now have people tell us who they are. We skipped that inadvertently because I was feeling uncomfortable eventually when the president is seated here, but is not fully aware of who is behind. That, as an MC, is a clerical error. I apologize. And I will move the mic myself.
Good morning. I hope it's still morning. I'm called Francis Banya, and I work at Church of Uganda. This is the hospital in Rukunjiri district. It's nice to be here.
Even clap for me and the elders. For me, you may not, because I said I am the freshly graduate, but I expected the residents to clap for me at least. No, Prof, I will skip you on purpose.
Thank you, Chair MC. Protocol observed. My name is Dr. Beckson Tayowa, and I'm also fresh, qualified in 2020 from Kampala International University as a gynecologist. I'm the medical superintendent of Ruharo Mission Hospital. I welcome, but we have also OBS and GYN services, and you are always welcome, especially the people who have time, the specialists and the residents, always welcome. And what you want? The HOD is here, sorry. Yeah, so but they're always welcome through their specialists, please. Let's have that in order. And whatever the service you give, we shall try to give you your transport refund back. So please support our hospital. I'm also helping to coordinate the Department of Obs and Gyn for Kampala International University, and I've seen some residents around. You're welcome. Thank you. Thank you for your support.
Thank you so much. And these are necessary. They are association issues.
Yes. Good morning, everyone. protocol observed. I'm Enyamitoit Samson Ralph from Kampala International University. I'm a resident, third year 3.2.
Welcome. So this table has the most massachusetts. You need to be getting hand claps from here.
Yes. Protocols observed. Good morning. I'm Muchungu Zahanabo Victor, first year resident, Obs-Gyn, Bara University of Science and Technology. I'm proud to be invited for this meeting, and I personally pledge to support AUGU.
Much better.
Protocol observed. Morning, everyone. My name is Sebanenya Joseph. I'm a second year resident at Mbara University of Science and Technology. You're all welcome to be here, and I'm glad also to be here.
Good afternoon. So, protocol observed. My name is Atupera Subira Mlangwa. I'm a third year resident from Mbara University of Science and Technology. And I've just come here, want to learn and see how Ugandan you're learning this AUGO, so that I can pick something to take where I'm going in Tanzania. Thank you.
I thought you were staying here.
Good morning, everybody. I'm by names of Dr. Saturday Pasco, third year resident of Zangain. And yes, and my email I will be hopefully in the next few months sending around. So please, Chief of Ruharo, remember this space. Thank you.
Names, first year resident, Department of OBGY, Kampala International University. I'm glad to be here.
Good morning, everybody. Yeah, I'm Dr. Kaimakas Irene, an obstetrician gynecologist who completed from Mbarara University 2021. Allow me to first recognize some important people in my life. Dr. Kayondo Musa, I recognize you. My lecturers, I see Dr. Mujenyi, my mentor, my friend, my son. I recognize Dr. Maseo and all others. I have just come in late, I'm sorry, but I recognize everybody of you. I'm a para 5+0. I'm happy that all my children are at school. I am now living as a single mother with my husband, enjoying life. So, but most important to note is that being an obstetrician, I'm also glad that I added my master's in public health, which I completed this year in February. So I'm multi-purpose. And being multi-purpose is that I have gotten these days, you pray for me, I choose the right opportunities, because I'm having so many opportunities on my table, and I pray that by July, I get the best of its kind. I work with the entire health center for in Chitagwenda district, and while there, I'm serving as an obstetrician gynecologist with Beira, Uganda, under Ministry of Health. And to recognize me importantly is that I'm the only female gynecologist in Toro and Bunyoro region. So while this side, currently I'm working with Kampala International University, I recognize my head of department, Dr. Beckson, and the other students I came with. I also have a private business in Uganda, which is at an average standard. I'm proud of it. And here I recognize everybody who invited me. Dr. Masembe, once again, thank you so much. I'm hopeful and I'm willing to support whatever comes abroad, because financially I'm okay.
Thank you very much, Irene. And you know, this is what OBGY does, miracles. We'll bring a sack, not envelopes this time.
Observed. Good morning. I'm called Dr. Diarhanga Paul. I'm a finalist resident at Kampala International University. I also recognize several teachers, our seniors who are around, and I'm here to know more about AUGU and also join the association. Thank you.
Thank you. Thank you.
I'm Cesario Masembe. I'm also a gynecologist, obstetrician, and a fertility specialist. I teach at Kabale University Medical School, and I'm a director for Neo Care Clinic and Fertility Center located here in Mbarara. Thank you. Enjoy the day. Thanks. My head of department. I'm a honorary lecturer at Mbarara University of Science and Technology for the last 6 years. Thank you.
Yes, let me stand next to this so that you can all look at it. I'm Dr. Mjenyi Godfrey. I'm a senior lecturer at MAST. Irene is my mother. My mother is called Irene, so as my student, she called me my son, and I call her mother. So I am a book writer of recent. I, together with the department, compiled information and put it in a book, which is available here, and you can take a copy at only 100,000 shillings before you leave. Irene, I know you have already bought, but you can buy for a resident. You said you're financially okay. Yeah, I work at MAST since 2002, and I director for Divine Mercy Hospital, and it's general hospital, but majorly in obstetrics. And I'm a mentor, I'm a researcher, and
wow, it's a lot of talent across. And now speed up from the secretariat.
Good morning, everyone. Is it still good morning? My name is Dr. Simwe Fiona, a fresh graduate from Bar University. Dr. Koyondo, I recognize you. Dr. Mjenyi, Dr. Kajabwang, Dr. Masembe. Like, sometimes I wake up and I'm like, I miss these guys. I miss the department. Yes. So I work at Tagata Hospital, and I am the secretary of today. The secretary job has followed me. Permanent secretary. Thank you.
Thank you, Fiona.
Yes, and Obs and Gain.
Good afternoon, everyone. I'm called Dr. Kakanda Ronald. I'm first year Obs and Gain resident, Kampala International University. Nice to meet you.
Good afternoon. I'm Dr. Odong. I'm a resident in KIU. I'm happy to be part of this mission.
Good afternoon. I'm Dr. Businga Julius, first year resident, Mbarara University.
Good afternoon. My name is Dr. Hilary Tudiahebwa. I'm a resident in first year KIU Teaching Hospital.
Good afternoon, everyone. I'm called Binai Sadeus, a resident, Mbarara University of Science and Technology, second year. This is my first AOGO meeting. I'm very grateful. I'm very sure I'm likely to get a number of new friends. It's my hobby. I'm just warming up. Thank you very much.
Yes, good morning, everyone. I'm Dr. Suada Suleiman Ibrahim, a second year resident at MAST. I'm so glad to be here.
Good afternoon. My name is Yala Kolakol. I'm a resident at the MAST University. I'm happy to be here as an observer from South Sudan. I will take the experience back home, and I hope people will benefit. Thank you.
Good afternoon. I am Tessa Sharon, second year resident at Mbarara University of Science and Technology. This is my first meeting in AOGO. I'm glad to be here.
Good afternoon, everyone. I'm Sister Rose Lila Chan, a second year resident at Mbara University.
Yes, good afternoon, everyone. My name is Dr. Gaba Collins. I'm a third year resident in Obsgyn, immediate past president, Uganda Medical Association, Ankole region.
Good afternoon. I'm Dr. Stuart Turanzomwe. I'm a second year resident at MAST. Thank you.
I am Birunji Wilson. I am a second year resident at MAST.
Thank you very much. Now, President, I hope you heard or saw what is across the talent, the multiple talent in the association. All that is what you have done for us. We appreciate. At this time, we'll invite Dr. Agaba David to give remarks on behalf of the residents as their chief resident representative.
Thank you, MC. I already introduced myself. I'm Dr. Gaba Collins, and I'm a third year resident in Obsgyn at MAST. So I will speak on behalf of the residents, I think from MAST and from KIU. So we are proud to be part of this meeting, the first meeting of its kind in Western region that brings together. You feel proud when your teachers want to associate with you. So we're proud of that. And we promise that we are going to subscribe and be associate members. And some of us probably very soon will be full members. And for us being part of this forum is important, way below target in terms of the reproductive health targets that have been set as the Sustainable Development Goals. This calls that we need to have more obstetricians, and we also need to do a lot of cutting-edge research in the field of reproductive health. So for us, we see AUGO as that place where this can be harnessed. One, would request that as an association, we start to fight for our own. How do we try to find some scholarships as an association for residents who might not be able? There are so many people there would want to do residency, but maybe they may not be able to pay for themselves. Can we find some scholarships? Can we support research? Because what happens, residents, the type of research we do is basically based on budget. But I'm sure if there were research grants for research, you would get a lot of cutting-edge research coming from these postgraduate trainings. And I think as an association, that is something that we can also look for. And of course, as we ask the association to do this for us, then as residents also, we have what we must promise to give to the association. One, that we are going to register and become associate members. I hope some of us register today. At least we need to raise about 10 or 15 of us registering. And support the activities of AUGO. When there are workshops, make sure we attend. When we are sent there, we make sure we attend. And once in a while, there are calls, research calls from AUGO. Let's compete for these small grants. For the time I've known, there have been about abortions. Maybe if we can try to diversify into the different fields, then maybe would attract more people. And our wish is to see AUGO taking shape of the discussions about reproductive health in this country. And I think that if we are to improve the reproductive health indicators, it has to be us, the members of AUGO. Sometimes you look at people who are planning for us, and really, you do not know when they last did their lectures on reproductive health indicators. So I think we need to get on the high table and make sure that we influence whatever is being done in this country. Otherwise, we are happy to be here. I'm personally very glad to be part of this meeting. And as I said, we pledge that we are going to register and become associate members. So to Dr. Kajabwangu, we can assure you we're going to have the most vibrant chapter. Just that we have had this, now I am going to organize and make sure we have the highest number of associate members registered this year. Thank you.
Thank you very much, Dr. Gawa, giving us the perspective of the residents. And I think he outlined clearly some of the requests that the association can pick. Others might be, immediate, others medium and long term. But having some of these, I think, on board would be great to build the institution. And I think for the next event, we don't have Rukabwe here, so I will take this rare opportunity and privilege to invite Dr. Ngonzi Joseph, the Dean Faculty of Medicine, who has really taught most of us here, to tell us about mentorship. Because certainly we all know this thing of, it's apprenticeship, medical practice needs, but can we have someone tell us what we need and how this can be done, and from the perspective of one who is at the helm of academia, but also who has been doing this at the personal level. So Dr. Ngonzi, the floor is yours.
As Dr. Pasco, please don't go until it works. Come here. Yeah, no signal. Why? We could use any other laptop that is compatible. It's okay. Okay, can get any other laptop. I am very delighted to be here. I also do not take it for granted to be among these great brains seated in this room. My name is Joseph Ngonzi. I'm an obstetrician, gynecologist. I trained at MUST. Yeah, my first and second degree, and then for my PhD, I obtained it from somewhere else. But all my professional life, I've been at MUST. I'm very glad to see our teacher, Professor Dan Kaye. Thank you for traveling all the way to be part of this meeting. The president of AUGU, Dr. Musana. Yeah, let's appreciate these gallant obstetricians who have traveled all the way from Kampala. The president of the Western Axis of UMA, UMA Western Axis President Dr. Asfas Owaraganise. Let's appreciate them. They do a lot of work. They advocate on our behalf. I'm hopeful that when the salary structure for Minister of Health is implemented, we'll have a few dinners on those who work with Minister of Health. Glad to see Dr. Kayondo, my brother, Dr. Mujenyi, quite a number of specialists, and Dr. Rogers Kajabwangu, the mini AUGU president for this axis. Thank you for inviting me and for putting this together. He's been making a couple of phone calls, and you're like, you know what? Please don't call me. I'm a member. I'm obliged to be there. By all means. Okay. And so Rogers, thank you. Is he around? Yes, please stand up for recognition. Head of Lady. He's a great mobilizer. Dr. Banya, I'm glad to see you, and all the residents in MUST and KRU. So I was asked to speak or to give a brief talk on mentorship. Some of the things I'll be speaking about emanate from my own, a couple of things. They come on their own money, and we sometimes take many months to refund their small fuel, but they still say, we are coming, we are committed to raising obstetricians with or without money. Long term. Okay? They are dynamic. They change as the mentee advances. My need as a mentee now may not be the same need 5 years down the road. And so I need to be cognizant of that fact. 3, they are reciprocal. It's not just me, the mentor, who's benefiting. Even the mentee who's benefiting. Even the mentor benefits. It's a two-way traffic. It's two-way business. As I expand some skills and ideas, I'm becoming better. As we plan for our meetings, I need to make myself better so as to remain relevant. The mentors who are here, they may not just be specialists, but also the residents and others. It's good to keep pace with what is happening. Otherwise, you buy yourself out of relevance. Number 4, they are active, largely shaped by the mentee, the mentee's needs. Very important here. Number 5, they are voluntary. True mentorship cannot be forced. There's an element of altruism. Don't say, I'm your mentor, you know it. Yes, whether you like it or not, it is me. What? There must be some degree of, of acceptance. Otherwise, you'll not force yourself on me. I may be looking out for another person who I believe is 100 times better than you. So please give me space. Yeah. So these are part of the characteristics that make the traditional mentoring relationships a little different from academic relationships. I don't have to be your mentor to give you a lecture, isn't it? It's my obligation. Yeah, whether you've understood or not, the exam will tell. But if you're under my mentorship, I'm interested in something even beyond the academia. I need to call you and say, my friend, as like sponsorship, coaching, I had my vice chairperson of convocation, MUST, the one who sits with the university council at graduation, saying sponsorship, scholarships. Very important. Career. You are advocating for career functions of the mentoring process, okay? Coaching, protection, challenge, exposure, and visibility. I'll just speak a few things around this and then run. Protection, very important. You can't be my mentor and you are exposing me to danger knowingly. Yeah, you say, he will harden. My friend, you're crushing me. You need to protect me from the monsters. You need to protect me from the, from the leopards. Then somehow I'll know that, okay, you have my best interests at heart. I'll open up to you even in areas I could have hidden. Protection, very, very important. Exposure and visibility. You cannot be a mentor having 100 opportunities and you keep them in your pockets, waiting for whoever makes you happy. The people that have been entrusted to you to take to the next level in career, you have also been given the opportunity to have some areas of exposure for them. When Dr. Kayondo has an opportunity to go to UCLA, okay, some of you fear being on the planes. Let me just bring it closer. To go to Kampala for an AUGU conference and present your research. And he sits on it. He's doing himself, go and explore yourself wider. Challenge. Not just protecting, but giving people challenges that make them grow, not break them. Okay? I don't believe in some people who want to break others. Say, no, he will hardline. No. Life is too short for you to begin breaking people. Personal functions, role modeling. Okay? Do as I say or as I do. Which one captures the heart faster? As I do, I may not even need to speak, but as you see me do, please go do it. Yeah, not speak 1,000 words. Mentorship, trans and cis. Okay? Some of these details you'll find them along the way. What are some of the attributes of a good mentor? Let's just have it and we see how to close this chapter. Attributes of a good mentor. Like I said, almost all of us are mentors to some people in some areas. Isn't it? Yes, Agava. Good listener. Thank you, too. Saturday, I see you nodding your head, too. Patience, Dr. Banya. Patient. You have to be very patient. Yes. Thank you, Dr. Banya. Binaisa. Compassionate. Okay. Yes. Friendly. You don't have to put on a face like a grader. And you always like, be friendly. Yes. Should be knowledgeable. Very important, okay? Yeah. I'll not mention names, but I'll give you a story. Dr. Kayondo. High integrity. You're not going to say, don't get money from patients, and then you're the expert in that. Isn't it? Don't speak ill about colleagues, and then you're the one who is teaching them how to speak ill about colleagues. So integrity is very important, isn't it? Yeah. 2 last ones, and then we move on. Irene, you're looking at me. Should be non-judgmental. Very important. Okay? Yeah. There are some residents somewhere who came out of a lecture and they were hakatwa. For me, that was a whole lecture. I didn't need to ask. So which poison has the lecturer given you? But when I explored a little bit, the lecturer was, okay, he had tried. But on some points, he was not updated, not knowledgeable. Yeah, so mentors, all of us are mentors. Please, let's go and update our skills. If you're having a lecture tomorrow, please go and read. Go and get the latest information around what you're going to teach. Okay? You've said most of these things here. Mentors, responsibilities, they are all listed here. Gives moral support, conducts individual meetings, keeps in touch. It's very key for you to follow up on the people that are under your care. Don't imagine that they'll, somehow go through. A mentor plays the part of the devil's advocate. It gives you different and broader perspectives of something. And is a trusted confidant. Now, this is very important. Trusted confidant. If I tell you my story now of how I'm struggling in my family as my mentor, I've not given you responsibility to go and speak it out on the streets. Okay? Keep it. Let it keep with you. If it is pressing you and you need permission to speak, come back to me and ask me. Say, you know what? It is heavy. Can I say it? Please. You need to be, to keep your mentees secrets. So on the mentors, they need to develop a plan. They need to communicate the plan. They need to, to communicate the purpose for wanting mentoring. Don't just come to me and say, I want you to be my mentor. Now give me specific areas. What is it that you'd want me to, to journey with you through? And mentees' responsibilities, there are quite many. They need to, respect the mentor's time, appreciate the mentor's effort, need to be open and willing to trust. If you want me to assist in an area, let me know that your skills on, on data analysis are very dismal. Then I will know where to put effort. Don't assume, don't stand aloof and you say, I know it all. I know it all. Just let go of some of those pressures. There are a few studies around mentorship. I will not go into them because of time, but you can find them. Qualitative studies, quantitative studies on the area of mentorship. Characteristics of successful mentoring relationships. There are themes generated from different studies on this area. Reciprocity, mutual respect for others' contribution, clear expectations. When they are not clear, there is blurring of vision, and you may end up knocking. There's need for personal connection. So there are many. There are also, to the contrary, characteristics of unsuccessful mentoring relationships. And there are a number of them: lack of commitment, lack of respect, lack of feedback. There's one case we were handling where the mentor, who was a lady, and I'll be done. There are 6 competencies when it comes to the mentorship journey. One is what we call maintaining effective communication, aligning expectations. You may expect so much that me being your mentor, I need to fund your tuition, my friend. Yeah, let's keep it within what is manageable, okay? I have to find you a scholarship or else I'm disqualified. Okay. Align expectations at the earliest. And you need to assess understanding. Or we take it. Eh? Are we on the same page? Can you play back to me what we've discussed? There's need to foster independence. As you mentor people, it's good that you lead them into the journey of independence so that you're not needed 100%. You see them from afar as they thrive, as they win bigger grants than you, and you rejoice. You're like, well, I was part of your journey. As they learn newer skills than you have, you rejoice with them and you know that somehow you contributed. Yeah, addressing diversity, promoting professional development. A mentor should lead you down the journey of you exploring your fullest potential, of becoming who you are supposed to become. And quite often, you will achieve professionally even more than what they have been able to achieve. It is okay. For the mentees, relax. Don't rub it into Kayondo's face and say, aha, now I can do a robotic cesarean section, not these things of nyama nyama where. Yeah. So I wish all of us a successful mentor-mentee experience as we grow the profession that God has privileged us to be in. Thank you very much. Good to see you, Lukabwe.
Wow. Thank you very much, Dr. Ngonzi. I think I will exchange at this moment with Rogers to take on the next steps. But as you spoke, I think you highlighted one of the issues we faced at the parent UMA. There was slight of a conflict between the seniors and juniors, and the key was, while the seniors taught most of the skills and knowledge and transferred to the juniors, they forgot that the behavior is what is observed. And I think they were expecting that in as much as they are giving them skill, then the behavior should follow the skill they are giving them. But the students were picking the skill by observing the behavior. And then the seniors were not happy with the behavior, which is actually a reflection of themselves. So Rogers, you can take on.
Thank you very much, Dr. Asfas, for ably taking us through the first few sessions we've had. Thank you very much, our speakers. So far, we had Dr. Kayondo giving us the opening remarks, and Dr. Collins speaking on behalf of the residents. And also, we've had Dr. Ngonzi talking to us about mentorship, a very important concept of growth, and also very important for us who are trying to come together, well knowing that we are from different various generations. I want to welcome also our colleagues who have joined us after the introductions. I saw people who have come from as far as Kabale. Dr. Dongleo, can you stand up for recognition? Dr. Dongleo is a gynecologist. But if you have a mother who has a gynecology problem and a skin problem, you can still help the mother. I think he's one of the first gynecological dermatologists. We have Dr. Kulo, also a resident from Kabale University. Dr. Kulo, I saw you. Yes, if you can stand up for recognition. I've also seen my old friend, the famous Dr. Horace Kizito. He's now putting on glasses. Having been treated for a bad corneal injury. Dr. Horace, you're welcome. The MS of disease also just walked in. I don't want to repeat the remarks that were made about him before. But Dr. Henry Lukawe, welcome. So, colleagues, thank you for moving with us up to now. We are obviously behind our planned schedule, but we are here and we are going to see how to finish the rest of it in time. This is what I think might work for us if we are to try and manage the time. We have some tea which we had planned to take much earlier, probably walk in with as we arrived, but that didn't happen. So what I request is that we go, serve, and come back with it. I know it is late, but tea is tea. It can be taken anytime. The Englishman says every time is tea time. So we'll serve and come back with it and have a working tea as we have the next session. I hope it will not take, it will just take a few minutes, and then we will see how to move. That means the lunch might come in a little bit later than is shown on the program. I thank you very much, and let's keep interacting. Let's keep this going.
Uganda Medical Association.
Yeah, you can hear me? Yeah.
But I put the mic near to mic. Can you speak little? Yeah, please.
Yeah, yeah. Am I audible? Yeah. Yeah, yeah. You can hear? Yes. Can you hear me? Yeah.
Can you speak something? Can you hear?
Yeah. Yeah, Deepak. Am I audible now?
Yeah, you can audible. You're audible.
Okay, okay, good.
Can you hear me, please?
Yeah, Deepak, I can hear you.
So what I'm going to do is that let me now start. Okay, I'll give a brief introduction, and then I'll
Okay.
transfer it to you. You can show the slide accordingly. Okay.
Okay. Sure,
I
sure.
think you can hear it very well. There's no problem.
Okay, that's good.
Hi, good afternoon, everyone. Am I audible?
think it's very small. The problem is that they're using that wire for the speaker for that one. So can you connect the sound system to the laptop? Please, please. Okay, then it's going to take another 2-3 minutes. I think we are connecting it with the sound system.
Yeah, Deepak. It's showing that your network bandwidth is low. Can you repeat what you said? It got broken.
No, I'm saying
Yeah.
that we are starting in next 2 minutes. We are just connecting it with the sound system so that everyone can hear it.
Okay. Sure, sure.
You want me to put laptop here? I can put it.
Yeah, yeah, Deepak. Am I audible? Yeah. Am I audible now? Yeah. Okay, okay. Yeah, yeah. Am I audible? Can you hear me? Yeah.
Suzanne, can you say something?
Yeah, yeah, Deepak. Yeah. Am I audible? 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 Yeah, Deepak. Now I'm getting an echo.
My name is Deepak Puri. I'm the Group Country Manager for one of the leading biotechnological company in India, BSV Life Science, Bharat Serums and Vaccines. It's a great pleasure. First of all, on behalf of Bharat Serums, I welcome you all and thank each one of you for your valuable time. I'd like to thank the AUGO, Association of Gynae Society of Uganda, for giving us an opportunity to be a part of this session. I'd like to really thank Professor Kai, Dr. Musana, and especially Dr. Rogers, who helped us to be a part of this scientific session. Today, presentation will be on two specific brands, which is a major concern which we are facing. One is on PPH, and another problem which we are facing is on rhesus factor. So we have with us a very two important person. One is a medical doctor from our medical advisory board from India, Dr. Zain Siddiqui, who is going to take up the session. And Reshma is our product manager. So Dr. Zain will going to take up some of the important points that what is the prevalence in Uganda and how we have to deal with those conditions with the management and treatment. So I'll take it to Dr. Zain. There might be some problem with the sound. Please bear with us. Thank you so much. Dr. Zain, over to you.
Thank you, Deepak. So good afternoon to all the doctors, and really it's a great opportunity to be able to present to this large group of doctors as a part of your regional conference. And thank you on behalf of BSV for this important privilege. And we would just like to share a brief overview about our company and then talk about a short presentation on the very important products that we have which can help the treatment and improve the patient outcomes. So let me start by sharing my screen. So I hope my screen is visible. Yeah. So just for the purpose of the bandwidth, I'll just stop my video. So just wanted to highlight 2 minutes on Bharat Serums and Vaccines. Now, we have a world-class expertise mainly focused on the research and development, which is part of our genes, because we have been pioneers for over 4 decades in developing and commercializing innovative products driven by the cutting-edge research. We also have state-of-the-art manufacturing facilities in our country and as well as in Europe, in Germany, which are certified by the WHO Good Manufacturing Practices and as per the UK MHRA guidelines. And we have a large infrastructure and a large global presence, of course, in India, where we have the headquarters, but we also have well-established international operations with presence in over 50 countries across the world. And we have the regional offices in the CIS countries, in Africa, and also in all over, of course, in Asia. We have dedicated support teams with the logistics, medical team, regulatory affairs, and marketing dedicated for international operations. And just to highlight a product portfolio, we are a forerunner in women's health, which provides comprehensive gynecological care from conception to delivery. And we have just highlighted the very important products that we have, which is Roclone, which is the monoclonal anti-D preparation, which is immunoglobulin. And we have a world patent on the monoclonal technology for the anti-D. We also have Endoprost, which is carboprost promethamine for the PPH management, along with the other products like Promegine, which is dinoprostone, and several other products. Also, we have the one-stop solution in assisted reproductive technologies, from down regulation to the luteal support, helping to turn the IVF ratios in favor of success. Here also we have the production facilities in Germany as well as in India, which are certified as per the UK MHRA and WHO GMP guidelines. And we have a large range of the urinary range of the HCG, the menotropine, as well as the high pure range, even the recombinant technologies for the follicle stimulating hormone, as well as the GnRH range across the for the ART. So with these few words, I would like to switch our presentation on the important product of Roclone, which is the RH immunoglobulin anti-D for the management of the RH disease or the RH incompatibility. So I would like to spend a few minutes talking about the important disease and the management. So this is just a brief outline talking about the prevalence of the RH disease and its complications, looking at the pathophysiology and the management, and then focusing mainly on the immunoglobulin, that is Roclone, about the mechanism, what is the importance of the monoclonal technology, and the pharmacology, as well as the clinical studies, which are very important, along with the last, which is the recommendation from the guidelines, which is the latest guidelines from the global organizations. So let me start with the introduction of the RH disease. So with this we are aware that RH incompatibility is a condition which happens when a woman with RH negative blood is exposed to RH positive blood from the fetus by a process called as isoimmunization. Now these antigen antibody response is mainly taken by the IgG immunoglobulins, which are very long standing long-term globulins which can persist for life and move freely across the placenta and cause the destruction of the fetal RBCs during the subsequent pregnancies. So they result in a very dangerous condition in the fetus called as Erythroblastosis Fetalis, or the hemolytic disease of the newborn that we say, and the severity can depend upon the fetal-maternal hemorrhage, the gestational age, whether it happens in the third trimester, as well as the enzyme activity of the fetus. So just to highlight that the mortality is very high if it is not diagnosed, if proper testing is not done in the country, and we do not give the proper prevention. So screening and the prevention is very, very important with the immunoglobulin, which is the anti-D immunoglobulin, which can significantly reduce this 24% mortality. And even the stillbirths, the risk is very high. Also, there is a high percentage of the neonates which also develop kernicterus, leading to the mental disorders, and the highest reported mortality has been reported in the Asian as well as the African regions, with around 38 deaths per 100,000 live births, which is a very significant and completely preventable mortality. So this is just how the etiology of the RH disease happens, and there are several conditions that we need to be keeping in mind, starting from the exposure during the fetal-maternal hemorrhage, either during the pregnancy in the antenatal period or after the delivery. Even a spontaneous or induced abortion can cause the risk of the RH disease, ectopic pregnancy or lack of prenatal care, even including some invasive procedures or the outpatient procedures like the external cephalic version or the abdominal trauma or C-section. So any exposure of the fetal-maternal hemorrhage can cause a sensitization, and these IgG antibodies then can cross the placenta and cause the hemolysis in the fetus, causing severe anemia as well as the hyperbilirubinemia, which can cause the neurological damage or death of the fetus. So this is how the pathophysiology progresses when there is RH positive father and RH negative mother. The first pregnancy is generally unaffected because that is the time when the sensitization can happen and there is a crossover of the blood which builds the sensitivity. And then we know that the IgG response is very, very potent and can be long-standing, can persist up to the life. So these antibodies can remain in the mother for lifelong and then these residual antibodies can attack the blood of the second Rh positive fetus. So the subsequent pregnancies can be damaged and there can be complication leading to mortality and morbidity. So the prognosis, we can see that with the prevention, we can significantly decrease the incidence of the Rh disease. We have seen studies where the hemolytic disease has declined from almost 40%, which is very high, to less than 14% with the introduction of the anti-D immunoglobulin. With the advanced care, the antenatal screening, doing the proper testing in each and every patient, we can reduce the Rh disease and its complications to a minimal level, as well as reduce the mortality rate, which is very high in the developing countries, in Asia and Africa, so where around 276 infants and neonates are affected for every 100,000 live births. So there are several complications that we need to prevent, including early miscarriage because of the intrauterine fetal demise. There can be fetal or neonatal anemia due to the exaggerated immune response and decrease in the oxygen saturation. There is a kernicterus or the jaundice where the hyperbilirubinemia can deposit in the central nervous system of the neonate, causing the mental disorders. And finally, the hemorrhage fetalis can happen due to the abnormal amounts of the fluid in the fetus or the newborn. And there is a recurrence of these complications in all the subsequent pregnancies. So that is why prevention is the best method to prevent this mortality and the morbidity. So how do we manage this condition? First of all, it is very important to identify the unsensitized pregnancy, do a proper blood group testing for each and every patient or a pregnant woman to identify the Rh negative status, and then start with the management with the prevention of the antigen antibody complex response. So the first line treatment is the prevention of the Rh immunoglobulin. It is the main prophylactic treatment which is recommended in each and every Rh negative woman when the alloimmunization has not occurred. So it is a preventive measure where there is Rh positive fetuses, either prevention during or after abortion or fetal-maternal hemorrhage have to be given the anti-D immunoglobulin. If that is not possible, then that can lead to several complications, making it very difficult to manage the patient. Then we can use phototherapy to treat the jaundice, but with the prevention, we can reduce the requirement of the phototherapy or the exchange transfusion, which may be required if there is a patient or a neonate with a kernicterus, or an intrauterine blood transfusion may be required if there is severe anemia in the fetus. So these are very expensive procedures which can be prevented by just giving a single shot of the anti-D immunoglobulin, which is the best measure. So looking at the RHD immunoglobulin preparation, it is a biological antibody derived from the human plasma that targets the RBCs, which are positive for the D antigen, which is the most potent antigen, and it is very effective in preventing the hemolytic disease of the fetus and the neonate. So we can prevent the RH isoimmunization by reducing the destruction caused due to the hemolysis. And they are very effective with the given in the right dosage. They are able to coat the fetal RBCs, having the surface D antigen, making the antigen antibody complex, which is deactivated. And the right dose is given, it is a short half-life, so it can be given once during the antenatal period between 28 to 32 weeks, and then once again in the postpartum period within 72 hours after the birth of the baby in a standard dose of 300 micrograms, which is able to cover 30 ml of the fetal whole blood. If there is a facility available, we can do the estimation of the fetal RBC in the maternal circulation using the KB test, which is the Clear Bedcade test. But many times that facility is not available in many of the hospitals. So there we can directly give the standard dose of the anti-D preparation, which is 300 micrograms. If there is a abortion in the first trimester in less than 13 weeks, then you can give a smaller dose of around 50 to 100 micrograms. But if this sensitization happens in the third trimester, then the full dose of 300 micrograms is recommended. Indications, there is a broad range of indications to reduce the Rh disease. Any Rh negative non-sensitized patient with Rh positive fetus should be given this anti-D preparation. And also for prevention in the other clinical situations such as antepartum or postpartum and sensitization, even obstetric complications like ectopic pregnancy or a threatened abortion or a fetal demise, including spontaneous or induced abortions or the invasive obstetric procedures, also the abdominal trauma. Wherever there is a feto-maternal hemorrhage, there can be a risk for the sensitization, which needs to be prevented. So the mechanism of action is very simple. It coats the D receptors, the immunological blockade of the receptors, FC receptors on the D antigen. And we have seen the clinical studies where very rapid clearance of the sensitized erythrocytes can happen with the intravenous infusion of the anti-D. So the incidence can be decreased from 12 or 13% to less than 1% with the administration of the antenatal as well as postnatal dosage, and that can suppress the immune response and antibody formation in the Rh incompatible individuals. So the administration, it should be given within 22 hours in the standard dosage, and it can be given either intramuscularly or intravenously. So the antenatal dose, a single dose should be given between the weeks 26 to 28 of gestation, and then again within 72 hours of delivery of the fetus. So coming to the part of the clinical studies, it's very important to understand that globally there is a large gap and there is a large prevalence of the hemolytic disease of the fetus of the newborn, and it is completely preventable. And we have seen global studies highlighting the dose gap between the number of doses of anti-D given compared to the amount which is required. And all across the world, we see that around 50% of the women who require this prevention do not receive it. That means we really have to increase the awareness and efforts for highlighting this completely preventable complication. So we also looked at the studies in the sub-Saharan Africa, where the dose gap was one of the largest across the world. And possible reasons mentioned in the clinical studies include a lack of awareness, a lack of availability, and or affordability. So we really need to ensure that the awareness is at a higher stage. We also looked at the clinical studies and superiority for the monoclonal anti-D preparation, which is recommended by the guidelines, compared to the conventional polyclonal immunoglobulins, which were available earlier. So there is a superior technology of the monoclonal, which is patented by BSV. And in this study, they looked at the efficacy and safety of monoclonal preparation compared to that of the polyclonal, looking at the proportion of subjects which are protected from Rh disease using the indirect test, and also looking at the adverse reactions. So procedure was an intramuscular injection of Roclone compared to the Rogac was given within 72 hours of the delivery, and they looked at the results. So at day 90 and day 180, so at 3 months and 6 months, we saw that the polyclonal was superior So the monoclonal was definitely superior, where none of the patients had a positive ICT result, whereas the polyclonal group had 2%, two subjects, which had a positive ICT results. Similarly, none from the monoclonal group had, even at day 180, there was a positive ICT result, indicating a negative ICT. That means the absence of the RH disease was seen in the monoclonal group, which is higher, 96%, compared to just 90% in the polyclonal group. So that showed that the better results were seen with Roclone compared to that of the Rogam, indicating that none of the subjects developed antibodies against the monoclonal anti-D. So there was a discussion on the Roclone, which is the human monoclonal antibody. It is the only monoclonal anti-D marketed in the world. We have the patent for it, and the standard dose of 300 micrograms was able to protect 997 out of 1,000 women from immunization, and no specific adverse reactions have been reported. Neither did the monoclonal anti-D did not result in any immunogenic reaction. So there were several advantages over the polyclonal, including the better batch-to-batch consistency, lesser protein impurities, and lesser risk of the disease transmission, including the availability with practically unlimited supply. So there is a monoclonal anti-D which is an attractive alternative to the conventional preparation. Coming to the last part, which is the guidelines, which is the recent guidelines given by the Global Organization of the FIGO, International Federation of Gynecology and Obstetrics, and they also combined with the International Confederation of the Midwives, raising the call to action for preventing the RH disease. This was published very recently in 2021, where they have given the high priority measures to be taken to prevent the RH disease, which should be done for each and every patient, to determine the maternal RH factor in early pregnancy for each and every woman, and for the RH negative women to identify the newborn RH factor from the umbilical cord blood. Then every woman should get the administration of the anti-D immunoglobulin within 72 hours of delivery, unless it's already sensitized, and the standard dose of 300 micrograms should be given if there is a sufficient supply, either intramuscularly or intravenous. Either of the administration is equally beneficial. Coming to the middle priority, they recommend the routine anti-D prophylaxis during the pregnancy between 28 to 34 weeks of 300 micrograms, even after a surgical abortion or ectopic pregnancy or abdominal trauma or fetal death. Then you can give the 300 micrograms if it happens during the second or third trimester. Coming to the low priority, the anti-D prophylaxis is recommended after amniocentesis, chorionic villus sampling, or external cephalic version, as recommended by the guidelines. So this is about the importance of the anti-D preparation to prevent the RH disease, and we thank you for the attention. Now we have a few minutes to talk about the second topic, which is the endofrost. So I'll just share my screen again with the second topic. Here we have the second product, which is the endofrost, which is carboprost-tromethamine, which is indicated for the management of the postpartum hemorrhage. Now we know that it is a very important complication which needs to be managed during pregnancy, and there are several definitions as per the WHO as well as the RCOG, which says that any birth is called as a postpartum hemorrhage. Similarly, RCOG has given a similar definition, and it is a leading cause of maternal mortality across, causing 1/3 of the maternal deaths across the globe in Asia and Africa. Around 14 million cases of the hemorrhage happen every year accounting for around 25% of the maternal deaths, which can be controlled, which can be reduced as much as possible. It is major burden seen in the underdeveloped countries, which is around 3.9% in the vaginal deliveries and higher in cesarean deliveries. So there are several complications which can be due to the PPH, including anemia, orthostatic hypotension leading to hypovolemic shock and causing the organ failure, as well as a respiratory distress leading to the death of the patient. And the severity of the PPH will be influenced by the rate and total volume of the blood loss. So there are several causes of the PPH which can be understood very easily in terms of the 4 T's, which is the tone, tissue, trauma, and thrombin. The majority is due to the uterine atony, which is around 70%. So there is a indication that we can give the treatment to prevent the uterine atony and cause the active management. So there is a main risk factor, a prolonged third stage of labor, which can be controlled, which can be reduced as much as possible. So the active management is recommended by the guidelines, which says that the prophylactic drugs should be given to promote the strong uterine contractions and also lead to faster placental separation and delivery, also reduce the incidence of the retained placenta, and most importantly, decrease the amount of the blood loss at delivery and the rate of the postpartum hemorrhage. So there are several guidelines which recommend it, including the RCOG as well as the Cochrane review, saying the management of the third stage of labor reduces the maternal blood loss. And there is an international joint policy statement by the SOGC, the Canadian guidelines, as well as the international guidelines by the FIGO, which says that active management should be offered to women to reduce the incidence of the PPH. So there are several advantages, including the reduction in the duration of the third stage labor and the faster expulsion of placenta and reduce the blood loss. And we have seen that compared to the physiological management, there are studies showing a significant reduction in the PPH and duration of the third stage of labor. Even the therapeutic oxytocin requirement may be reduced if we go for the prevention with the active management. So that is the best preventive strategy which is recommended by the guidelines, including the American, international, or the WHO. They say they include the administration of the uterotonic agents after the birth of the fetus and to produce the adequate uterine contractions and speedy delivery of the placenta as a prevention. So these are the uterotonics for the PPH. We have the oxytocin and the analogs. We have the older drugs, the ergot alkaloids with the ergometrine, and we have the newer prostaglandins, which include the carboprost and the misoprostol. So these lead to shorter third stage of labor and less risk of the PPH. So here we talk about the carboprost, which is the endoprost that we have available and which is part of the national guidelines. So it is a synthetic analog of the prostaglandin F2 alpha, which induces fast and extended myometrial contractions and reduces the blood loss and requirement for the blood transfusion. So it is a very fast acting drug with peak plasma concentration approximately reach 20 minutes following the intramuscular injections, and it is excreted in the urine. And there is approved indication for the management of the PPH given in the dose of 0.25 milligrams, either intramyometrally or intramuscularly, which can be repeated every 15 minutes for a maximum of 5 doses. So this is recommended by the RCOG guidelines and the international guidelines. And there are several studies with the evidence that carboprost helps in the fast and extended contraction of the uterus, and it has a very high efficacy with a good control of the PPH in 84 to up to 96% of the patient. and significantly reduces the blood loss and requirement of the blood transfusion. Here we can see some studies where carboprost has proven to be effective as compared to the methergine to reduce the or manage the third stage of labor and reduce the amount of the blood loss. So it's a valuable and potent uterotonic and should be the choice of treatment over the other drugs like methergine. Here we can see there is a significant reduction in the duration of the third stage of labor, and the mean blood loss was significantly less compared to that of the methergine. So that is another very important advantage. Also, we looked at the comparison with oxytocin, where we found that again the amount of blood loss and even the hemoglobin levels was significantly better with the PPH patients in high-risk patients undergoing the cesarean delivery compared to that of the oxytocin. So here we can see the arms of the carboprost compared to that of oxytocin had a smaller reduction in the hemoglobin levels and a blood loss was much better in the carboprost group. Also, we can combine, there was a group which combined oxytocin and carboprost and which was much better than the oxytocin group. Also, we looked at the active management of the third stage of labor for the carboprost compared to that of the oxytocin, and intramuscular carboprost was better than the oxytocin in reducing the active management or the duration of the third stage of labor. Finally, we also looked at some of the other comparisons versus oxytocin and methyl ergometrine. And here also the three groups were compared, and it was concluded that carboprost shortened the third stage of labor, minimized bleeding, and reduced the postpartum hemorrhage compared to oxytocin and methyl ergometrine. And here we have some guideline recommendations for carboprost, where carboprost has been successfully used in management of PPH without resort to surgical interventions in around 85 to 95% of the cases. Even if the bleeding happens in cesarean section, intramyometrial injection of carboprost may be used, or even the laparotomy. Following the failure of the pharmacological management, intramyometrial carboprost injection should be the first line measure once the uterine is exposed. So to summarize, we have the etoprost, which is the carboprost, which is a prostaglandin PGF2 alpha analog, which is approved by the US FDA for the reduction of the PPH and causing the uterine contractions. It is available in 125 and 250 micrograms, which is administered intramuscularly at the delivery of the anterior shoulder of the baby, which has a very fast action, which stimulates the myometrial contraction in about 3 to 4 minutes of administration, rapidly metabolized in the local episiotomy or a prolonged labor. Low risk includes the nulliparous women with good history, hematological, obstetric, or the good general health. There is a management algorithm flowchart of the atonic PPH with endoprost, given the endoprost 250 micrograms in the intramuscularly in the gluteal region for the best effect to control the hemorrhage as much as possible. If it is not controlled, we can repeat the dosage up to max 8 injections, and then if it is controlled, if it is still not controlled, then you can go for the surgical procedures like ligation or hysterectomy. For that, we have the Roclone as well as the endoprost. So now I'll stop sharing and invite any questions and comments on these topics. Thank you. Thank you, doctors.
We discussed about two major problems. One is PPH, effective management available with us, that is carboprost. And another one is for rhesus factor, which is also another major problem which I have seen it. And it's our even endeavor also, it's from our side also, it's very important for the doctors to tell the patients to go for the blood test. Because unless and until if the blood test may not be possible, it's very difficult for the patient. Otherwise, the patient may keep on having that problems of abortions, going on. So we have covered two of the very important products out of a total important products which we have it. So thank you so much. Thank you so much for your patience, for your valuable contribution. Any queries and questions if anyone has had on these two topics? The products are already available. The products are available in the market. We are distributing our products through Abacus. Abacus has many branches, mainly in Kampala and even in Barara also, and wherever they have it. I think I have put my product list. I have given my contact number also. Even the price is also there. If anyone has any concern, they can talk to me any point of time. But at this moment, if you have any concerns, please, you can discuss in the forum. Otherwise, you can talk to me also. Dr. Masana? Yeah.
Thank you very much. Thank you very much. I think, first of all, I'd like to commend BSV, Bharat Seraman, first of all, for standing with AOGU as a partner. Many of us, especially the younger doctors, do not understand the partnerships we need with the pharmaceutical companies, especially in making sure our supply chains are functional. But also for CPD, some of the things we used to study in books actually then become real because somebody is introducing it to a product. Then two, I am not an obstetrician. I consider myself a gynecologist. I don't see many pregnant women, but because I'm dealing with a lot of hormonal disorders, cancers, and of course some of the complications like PPH, I think carboprost for us, I work in the private sector, so carboprost is a very good product, especially when given immediately as you diagnose the PPH, because it tends to instill an almost immediate contraction, and it's a sustained one. Then, of course, for me, I normally advocate for my clients because I use a lot of Erythroblastosis. Yes, and I think so one is I think the cost needs to come lower because as the diagnostics for endometriosis, fibroids improve, then of course our clients need reasonably priced products. And I think that that is an area that you may need to also factor in. I think carboprost is part of the new guidelines for treatment of PPH, as far as I know. And I think that that partnership should continue to grow, the CPD, and I think some of these things can also be aided as part of research, local research, just an SHO does maybe a laparoscopy study, fertility studies within our small context. I think that would go in a long way. But as I think AOGU, we want to continue the partnership. And I was glad to find you here. When I heard BSV was here, I was like,
Sana, thank you so much for your nice words. I think we will going to contribute now, with even at Kampala also. And I think we are coming now to every region, in fact. So this is the first meeting, but slowly and gradually we'll be doing a lot of meetings, sir. And that will be in collaboration with your AGO only. So that is what the plan we have it. Not on one particular topic, but there are many topics we have it. Very soon we'll be doing it one meeting with the Fertility Society also. Very soon on ovulation induction. So we'll be calling one of our international speaker also on that. So BSV will always be there in collaboration with the society. And we have couple of products. We want to collaborate with you guys, everyone. And we have these world-class products which is proving really very well. Like carboprost is a major success which we have seen. I think with just one injection, we can control the PPH there itself. And that's a thank you so much to the guy, to the association that within 2 years of its launch, now it is in the guideline because of the success rate. 96% of the patients, they get results with just one injection. And that is what the world-class products we have. So thank you so much for the nice words. Thanks everyone for your patience. I think if anyone has any other question, please. So now I think we can move to the next, topic. So Dr. Zan, I really thank you for a valuable time. I think thanks everyone from everyone. Thanks for a valuable time for the presentation. Thank you so much. Yeah.
Thank you, everyone.
Rogers, over to you. Now we can come to the main topic.
Yeah, thank you very much. Let's clap for Mr. Deepak. Okay, that clap was for him sharing the product with you, with us. I would like us to give him another clap on behalf of his company for sponsoring this activity. So I met Deepak not so long ago, and he had come on one of his marketing trips. And then I suggested to him that we could have such a meeting, and that we were looking for some support to have it. You know, this is the Acacia. You don't just come and bring people. You must pay for the venue and for the food. And BSV has done all that. We are really grateful. So please remember that when you're prescribing the products. So I want to thank you again for keeping with us and moving forward together. If you look at our program, I think we have made some strides, a few things to cover, but a good part has been covered on the program. And I hope we are still moving together. We have a few things remaining. Let's keep together and finish them. The next part of today is very important because some of us have been asking, what is AOGU? What is the agenda for AOGU? Why do I need to be part of it? I could not explain that to you because you're always here with me. I had to invite the president of the association, Dr. Musana, to come and share with us the AOGU agenda and the vision that AOGU is running on currently. But as I hand over to him, I would also like to introduce the executive director of AOGU, Professor Dan Kaye. The people from must know him as an external examiner, but he has not come in those shoes today. Today, he has come as a member of AOGU and as the executive director. And we want to commend you, Professor Kaye. So, ladies and gentlemen, let's listen to Dr. Musana, the AOGU president.
Thank you very much. As I try to settle on the issues of the IT, I hope this can work really. I am Othniel Musana. I'm an O&G, but I prefer to call myself a gynecologist. I am trying to avoid obstetrics at all costs. And at the moment, I am a gynecologist by training, and that's by fellowship. I'm also the president of AOGU. At the moment, I'm self-employed at the moment. Not yet at the level of investor, but I've left employment. I'm now self-employed. Soon I'll be a business owner. And later I think I'll be an investor maybe a business owner like Dr. Masembe and other people. But later we want to have investors as obstetricians and gynecologists. I would like to share a little experience. This year I made 42 this year. And 9 years ago, I finished my M.Med in 2013. Means I'm still a fresh graduate. Not yet very advanced, really. But I am a product of mentorship. And some of my mentors have been presidents of AOGU. So when I come to regions like Mbarara, sometimes I'm looking for people who can also mentor me in other things. Because I'm also still at a phase where I am growing. Why I resigned was to see if my name was worth some, but that's a work in progress. In 2006, when I finished my internship, my dream was to be a neurosurgeon. But I then met a man called Professor Kong. You may have heard about him in some circles. And he forced me to go into obstetrics. Of course, there was a big fight, but eventually I needed employment as a medical officer. So I joined the department. And he used to be on my case every day, until I learned obstetrics. So 2 years later, the only skills I had was obstetrics. And when I came down to do my assessment and say, what do I want to study? I said, let me go back and do surgery. So I went to assist the neurosurgeon, and we spent 13 hours. I could not see, but I was retracting. So I gave up. I said, no, now let me go and do cardiothoracic surgery. I went and retracted in a thoracotomy. I got tired. I said, no, I will not do that. So eventually I decided to apply to Mulago. So of course, in Mulago, sometimes people give you your reference letters when they are open. So he gave me mine when it was open. Now I had colleagues in the department still. At that time, in my head, I believed I was better than these chaps. And I knew it skill-wise. And so he gave them very good recommendations and said, they can study, they are wonderful there. So when I opened mine, he said, he's not yet ready. So I go back and ask him, boss, what is your problem? I'm better than Okulo, I know some of them, better than Nansoga, but why are you writing here, I'm not yet ready? He told me, no, don't worry. So he gave me a job as a research coordinator at MRC at that time in cervical cancer. And of course, I kept learning things. Eventually, I got a scholarship to do my MPH. I finished my MPH. But my heart always belonged to the clinic. That's where my passion was. So in 2010, somewhere there, 2009 there, he then said, okay, now you're ready. Now, my MMed was very simple for me because I had learned things my colleagues did not know. And I became the head of department. Now, this is not news anyway, but the day I put pen to paper, there was a strike. People said, how do you put a young person as the head of department? And eventually the MD was fired. But to cut the long story short, from 2014 to 2019, the 5 years, I received a lot of training as a young person. Okay? And I learned a lot. So I was being mentored in the clinical disciplines. I was being mentored as a leader. And eventually I developed the skills for leadership. So when I stand here to speak without stammering, people who knew me back then may not understand that I learned how to talk. So I don't stammer. I can spend 10 hours talking, but I'm a very shy person. But I also learned to defend myself. But I also learned to understand, especially when I look in this room, and why I'm excited to be here, is in this room there are many young people like me. When I say young, I think it's less than 45. And I'm saying that we need to take part in the decisions that will affect our future, because an obstetrician gynecologist, I think, will practice for anywhere between 20 to 30 years of their lives as a specialist before they reach retirement age. And on average, most of us finish around 33, 34. So you have another 30 years to practice. But you're not getting involved in the decisions about what you will do in the future. So if I decide for you when I'm retiring, one of the things which struck me when I was head of department was one of the MDs said, but these young people should not get money. Let them wait. I'm like, but I am strong at 30 and 40. So if I am 60 and I'm retiring, of course they'll look for another new mechanic, because our work is mechanical. They'll say, we need another obstetrician who can do 40 scissors. Okay? So I must get paid, not just in money. I must be mentored, I must be paid cash, I must be trained when I'm in my prime, so that when I'm reaching the other age of where I cannot do the manual work, then I am doing the mentorship. You get it? Otherwise, if I wait until that time when I can no longer work, of course they'll bring a new guy from Bust to take my position, because some of the work is purely manual. And in Uganda, people have failed to appreciate the value of the seniors. They think the seniors are there to clear lines. When they see Professor Kaye, they're asking, but you only did 2 scissors. And Dr. Musana did 40. Forgetting that at that level of seniority, their work is entirely different. That's why you find in Mbarara, RRH, I think if I count the specialists in Mbarara, not the ones of MUST, the hospital, I don't think they're more than 5. And they expect them to do all that work. The good thing is they have SHOs. So that's just a bit of my story. I would like the young people to actually take part in designing what you want to see in the future. If you don't take part, then you cannot blame anybody. But also this is the time for us to make the mistakes. Because some of us have mentors. You say, that guy told me you're not ready. You get it? It means he had seen other things I don't see or understand, and he said, you take this path. And I think that path took me in a much better place. Even my scholarships, we are all paid for. I didn't pay for a single scholarship. I was taught to go and talk to big people. Tell him, Dr. Kaye has money. He has money in PPH or this. Go and talk to him. He will give you a small grant. And you go and talk and they give you a grant. Something like that. So my belief is that I'm seeing a lot of young people who look like me. But I may have a lot of gray hair. This came after I became head of department because it was a stressful job. And in 2019 I said, money, let me so try and go and look for money. So I'd like to encourage the younger people, when you're placed in a position of responsibility, throw your head there and see. You will learn, but also you will learn to appreciate what seniors do. I think failed the most interviews in Uganda because sometimes I put in my application, I know I will not get the job, but I want to hear when they are interviewing for professor, what do they ask? So when I know, okay, that's what they ask, then I can better prepare myself for that role. But when the chance comes, I know what they ask senior consultants. I know what they ask professors. Okay? Even I know I'll not succeed. So, EOGU. AGU is the Association of Obstetricians and Gynecologists of Uganda. Literally, we have 2 components, obstetrics and gynecologists. When I call myself a gynecologist, I have deliberately chosen not to go into obstetrics. Obstetrics is a well-paying field because most women are in reproductive age. Nobody cares about the cancers, the menopause, but fertility, I think, has now grown also because of obstetrics. People need to deliver. So AOGU is the body that is a health professional association. The HPA is not a regulatory authority. In Uganda, the regulator is UMDPC, the one which gives us licenses. But UMDPC is allowed to delegate some of its powers to the associations because professionals know professionals. And we're the ones who know what our work will look like. So the founders, AOGU has been in existence for 37 years now. And those are some of the founders. I know a few of them. I know Professor Mirembe. I know Dr. Jotham Musinguzi. The others, I hear about them in tales. Maybe Dr. Kaye knows them, but I hear about them. I'm still a fairly young person. So these people got together as professionals. Many of them were members of those UK things, Paracog and other things, but they felt that they should get together in an association, mainly for continuing education, and getting to know what other people were doing within the country. So we owe a lot of our success to those founders. So why should obstetricians and gynecologists associate, or why should they congregate? Number one, as I told you, AOGU is the body where we congregate, not just obstetricians, but the people we also do our work with. Those includes obstetricians in training, the SHOs, the midwives, and any other people who actually help us achieve our work. So we have what we call associates, and those are the SHOs or the residents or the midwives. Now, there are benefits to you as an individual and also for us as a group. And that's why sometimes we're here. Dr. Kaye may add on later. One of them is job opportunities. Your teachers will employ you. I'm sure most of the lecturers here may be trained in from here. So it meant that they get jobs immediately from. But also some of the people who train you or who mentor you may link you to jobs. Whether in Kampala, whether in NeoCare. I'm glad NeoCare is now an employer. I hope he's employing more people so that people will get jobs. The other one is networking. Networking is very important. Many people will think that, I'll use myself because I have no, Dr. Sana is the best student of his class. No. It is because I know people. So when I go somewhere, I make sure the first thing that must stick on people's lips is my name. So when you live here, you should know Dr. Musana is a gynecologist and you refer to him. End of story. Because I have to eat. So networking is very, very important. Many of us, when we were SHOs, we were very shy people. If you're shy, we shall leave you behind. Because nobody will remember you. But if you learn how to talk about yourself, you will make your networks. So if they call you for meetings, they call you for this, please get in there and make sure that at least when Dr. Kaye is talking on a topic, raise your hand. When he asks you, yes, what do you have to say, young man? You say, Dr. Kaye, I am Musana, and I entirely agree with you. So that they remember, and at each point just keep raising your hand, so that they remember you. The people who get up there are not necessarily the best. They are the ones they remember. So when the president is naming a cabinet of his historicals, they're the ones he remembers because they were always here. So even us as networks, we must remember you. I cannot forget Dr. Munjeni. I met him once when we came to Senate PPH guidelines, and he spoke. And I'm like, now I've met him today. He has launched a book. I can never. So if they ask me for an academic, the only name I remember in Barara is Dr. Munjeni. If they ask me for a writer in AOGU, the only person I know, unfortunately or unfortunately, is Dr. Kaye. So they ask me, Dr. Kaye is the one I know. That's the importance of a network. So don't hide in Chisizi and work and break your back. Let Dr. Kaye know your name. He will include you in his papers. And that's how you begin to build your portfolio. Then, of course, staying up to date with industry news. Things are changing rapidly. Now there's NeoCare there. NeoCare may be lagging behind because they don't know what's happening in Kampala. But if you have a network, you'll know where the jobs are, where the money is, opportunities are, things like that. Then many of us are potential employers. Even you may employ me. I keep telling my interns, even SHOs, I will behave well when I am with you. I'll even teach you because I know potentially you are my employer. Medicine, your intern can be your boss the next day. You know that. So you must behave well because they are potentially you're a future employer. Don't say because I'm the most senior, I've been here long. That guy will be your employer. And you'll have to say, yes, sir, yes, sir. So you must know. So in professional associations, you're potentially dealing with employers. Like me in private sector, I depend on referrals from Umbarara to survive. Others I will not eat. Then of course there's professional development. A lot of times we get to know about things because we are talking to other people. Now I know Mbarara has begun a fellowship in Urogyne. Okay? So potentially, I can come and say I want to apply. There is oncology and other things. Of late, under the project that was dealing with abortion, there is a lot of advocacy. A lot of advocacy, meaning that for our members, we are dealing with issues of welfare. Means we go speak out. Those of you who notice me writing things on NASMEC site, I don't know how many of you are members there. I keep posting something. Which when I post something, then I back it up with a meeting somewhere to say, but we have this guy in this hospital, but he's employed as a medical officer. And of course, the PS will write a letter and things happen. So when we come to some of these areas, we make sure that our members are sort of fixed into the system. Right now, as a president, I'm advocating for obstetricians to be at Center 4. Because that's where obstetrics begins from. We have a theater, we can do Caesar, we can do hysterectomy, we can. But also, in some places where there are ONGs at Center 4, things have changed. I may be employed as an obstetrician gynecologist, but because, as a medical officer, but because I'm licensed as an obstetrician and gynecologist, I must give specialist skills. They are not some medical officer. The skills, I'll sort them, I'll keep them in the box. I'll have to use my skills to deliver the service until a position. So, in my opinion, we must have them at Center 4. But also, now I'm advocating, because some of the reasons we had medical officers at Center 4 are almost dying away. We did not have enough specialists. But this year alone, I think we have about 150 SHOs in medical schools waiting to graduate in the next 3-4 years. Where shall they go? Okay? Then, of course, sharing information. So LGU began in 1985, but the roles are changing, and over time, we want to consolidate LGU as the main, as the go-to organization in reproductive health. That's where we are trying to go. So, what has changed in the last 37 years? Number one, 1985, I think there was only one M-Med. I'm talking about M-Med. One M-Med, school training obstetricians. Now there are 5. Okay? But there are more coming. Guru is coming. Sitema wants to enter the fray. Soroti wants to enter. I think, which other one is coming? I think another one is, there are many more coming. So I think by the end of 10 years, we'll have about 10 schools training M-Med people. It means that number has to be absorbed somewhere, either in the public or in the private sector. Now, 1985, from the stories I hear, there were about 4 students in the whole 3 years. Now they are graduating at least, graduating. Now, almost every year, Mulago is graduating about 25. Okay? Mbarara is pushing about 15, that's already 40. Then you add in Zambia, we are another about 6 or 8, 48. Then you add Kabale as and when they push in. So you'll find that almost every year, anywhere between 35 to 50 obstetricians are entering the field. So where are they? They're not in government. Because we can count the ones in government, we know them. So where are those other people? So, by that time, 85, there were a few specialists nationally now. But the estimate is over 400 specialists. Some may have gone into other businesses after failing to find work. But they're over 400. And most of them were employed in government in 1985. But now, private sector must be the biggest employer at this moment as I speak. So we are happy to find that we have some business owners here. So things are changing. In 1985, there was no super specialization. Now we have women's hospital, women's specialized hospital at Mulago. So it means that we can no longer do business as usual as obstetricians. So it means eventually with time, you'll find the general obs-gyn will be further down the chain. Center for General Hospital, and things are changing. Now, this is my own point, but this is what I think, that in those years, because of the lack of skilled people, and as a specialist, there was a need to shift the task. But in the event that there are enough specialists in the country, whether in the public sector and whether in the private sector, that need is actually going away. The people advocating for clinical officer schools to be closed because there are more MOs now, unemployed by the way. So, shall we have a need to task shift eventually? Because these 50 obstetricians have to get employed. When I speak obstetricians, that is our mandate as AOGO. We don't speak for the midwives, though we support them. But our mandate is mainly to the obstetricians, our members. So, our mandate is to promote professionalism, undertake research, and many of you have been getting some seed grants from a project that has been run by AOGO on abortion care and other things, and represent our members locally, nationally, wherever our members are, we represent them. So you'll find some of the times we are fighting with DHOs, we are fighting with hospitals to make sure our members are, their welfare and their pay and upgrades done. But our vision is to be leaders, and I'm calling upon us to be leaders wherever you are. So an obstetrician is by nature a leader of the team. So once you enter a place and you're working, you become the leader. I can't say I've gone to neo-care as a gynecologist and I don't leave some value there. As an obstetrician, I must leave value there. And if it's not my own place, because I have to lead. Then of course our mission is to advance excellence. Now we have obstetricians who are clinicians, most of us. That's practice. We have obstetricians who are teachers, lecturers. That is education, and they all must be excellent. We have obstetricians who are researchers. Some are combining practice, research, education, research, like the ones I saw here today. Another thing is there are obstetricians who are involved in not clinicians, not educators, not researchers, but then NGOs and other things. So we need to collaborate with them and make sure that wherever they are, we have those collaborations. When we're talking about the drug companies, pharmaceuticals, we must make sure we keep those collaborations alive and strong. Otherwise, we don't function very well. Then, of course, advocacy. A lot of my work as president is advocacy. Sometimes I kill my own fellows because I have to advocate. If somebody is stepping on the others and it's not right, then of course we will speak. Sometimes you have to do that. But also advocate for the patients. When I'm saying reduce the cost of drugs, I'm talking about the patients. Okay. So, AOGU runs its work through strategic plans, and the recent one is the one ending in 2024, the normally 5-year plans. And the main objective is to provide strategic leadership. Now, when we are coming to the West, we want to provide strategic leadership. We want the Western chapter of AOGU to be very strong, okay? To have its own leaders, to have its own rules and regulations, to have its own, build their own organization there, strategically, to make sure that reproductive health and other things are done. If they can even open a business strategically. I don't know why Dr. Masembe is not making his company public, is it called? IPO, to get more investors. All these guys are investors. They can give you company money, you spend money, and it grows. And of course, primarily we want to make sure that our members are competent. We don't want obstetricians and gynecologists who don't know what they are doing. That's why we go through training. That's why we go through CPD. And AOG is going to become more involved in CPD. And that means AOGO Western region must have its own CPD calendar. Because there's something I'll talk to you later that is coming up about CPD. Then, of course, we want to make sure that the services we provide are of quality. But these ones we do in partnership with many other bodies and stakeholders. Now, what you'll notice, you've been hearing NASMEC, MPD, SRA, and what? Our members are leading there strategically. So if our member heads a subcommittee, this is our agenda, drive the agenda this way. Make sure we are accountable. Make sure our people are known. Make sure if somebody is in Chisizi, we know his name. things like that, so that we can promote. So we must lead in many of these. So we're needing development and dissemination of guidelines and standards. Some of you came for the guideline dissemination here of PPH, and more are coming. But we want these things to be done by the regional teams, including mentorship. Of course, advocacy locally, but also we want AOGU to be a strong organization. Now, I think 4 years ago, the abortion that is advocacy for the prevention of maternal morbidity and mortality from unsafe abortion. Okay? A lot of their work is advocacy, and with advocacy comes visibility. I liked when NeoCare posted our first IVF baby. It makes them more visible. We now know they are there. They're no longer an underground organization, they are visible. Okay? So we want to be visible wherever we are, and that project has done. If you move outside, you'll see the car bought by the project with our brand, a big one. So whenever we go, people will recognize us. But also whenever we enter offices, because of brand recognition, okay, people will listen. Okay? So where you are, what is your brand as a person? So make sure that you're competent, but also you can sustain. So how is AOGU governed? AOGU has an AGM. The AGM is all the members who are subscribed up, and they have a right to vote and choose their leadership, but also reject whatever the leadership is doing or approve. So they approve budgets, programs, and other things. Then the AGM votes the AOGU Council, which is chaired by the president. Now the council has representation from the regions, like for example West, and we want to make sure our regions are very strong. The center must be strong, but the regions must be very, very strong. You get it? Because most of our members are in the regions, and the center can just coordinate a few small things. Okay? But we want our members to be strong in the regions. Then of course the council then delegates to the executive committee, which is about 6 people. And I think Mbarara has had a past president, a past immediate vice president, and a few other people in this area. So the committee is led by the president, and then that committee delegates its power to the executive director, who does the day-to-day running of the association. So most of the things you will see are actually done under the docket of the executive director, and that's Professor Kaye. So what are our priorities going forward as AOGU in that plan? These were negotiated a few months back in Jinja. One is we need to increase access to obs and gyne services to citizens. So when I hear NeoCare, it means they're increasing access to the citizens. Otherwise, they would come to Kampala. Okay? When I hear there's Urogyne in Mbarara, why can't the Urogyne department become the center of excellence in Uganda? Something like increase access to the services. If it's oncology, Mbarara should give me a job, I come and work, because the pay is going to get better now. So I'm also advocating for myself. So we must make sure we have obstetricians wherever there is a facility that can support an obstetrician, which is Center for. You have an O and G there, people not die of PPH, most likely, because they can do a whole range of things. Improving the quality of existing services, MPDSR and other things, CPD and other things. Then of course, we want to have an obstetrician who is of quality. When I came here, I was seeing guys in expensive suits. I'm like, these guys have money. And I want obstetricians who have money. Their quality of life should be good. They should drive a big car like, I think for Dr. Masembe. They should be healthy. They should not be lousy. But quality of the human resource should be good. We must make sure that our younger people actually want to become obstetricians. Not surgeons, obstetricians. I became an obstetrician because the guys who mentored me have swag. When they walk into a room, people keep quiet. I'm like, I want to walk like that guy. If he walks like that, I walk with a limp. So, priority number 1. So as an SHO, please try to copy. When I came here, I always look at Dr. Ngonzi sometimes. I'm like, this guy is a pastor. He's learned how to speak well. He's to the point. So I also want to be like, let me copy one thing from him. And then, So priority number one is developing our members, leading the development, review and update of evidence-based bundles for the major killers, and those are the major killers. And those of you who are on NASMEC, MPDSR committees, you know our members are there, leading those processes. It's not by mistake they are there. No, they are placed there and supported from the center. The other one is increasing access. We want our members to reach every Ugandan woman who needs, whether it is fertility, oncology, Urogyn, we want our members to be there. So, as we increasing access, we have the committee on LGU called Professional Development, Ethics and Disciplinary Committee. This committee was constituted and their scope is to, their work is to develop O&G practice in the country, give guidelines that may include training. There are many universities cropping up. We must make sure the training is standard. Okay? And some members, Dr. Waswa is on that committee as well. People in practice. When I finished my M.Med, I was lucky and I became a boss immediately. If I have learned wrong things, God bless the Ugandans. So practice must be standard. Research, and the gurus in research must be out there, making sure research is done. Then accreditation. Eventually, we would like to accredit our colleagues. Many of us are called upon to accredit qualifications of other people, but also institutions. And we want to be able to do this work. Then what has changed recently, the super specialties. Many of us are actually unemployed because we don't have those structures in the scope of practice of the government. Now with women is coming on, with Imbarara growing in Urogyn and other things, it means there's a recognition that these are important. Now, the scope of practice, I think may have, that's my opinion. That's my personal opinion. If I have an obstetrician, gynecologist in a district hospital, what is the medical officer doing removing a uterus and removing fibroids? If that case came to me in the council, I would say negligence. Because there is an obstetrician and is the one who is skilled and competent. But if there is none, maybe I'll consider. But if the specialist skill is there, like where I used to work at in Zambia, all the cancers were done doing all the cancers. But I had more senior people. But I was the gynecologist. When I see fertility case in Zambia, I would just tell them, go and see Dr. Zake. Because he's next door. So why should I begin trial and error? You know what trial and error is? No, your colleague is next door. And they are better skilled in these things. So send them there. But then a scope of practice. And of course we want committees. Now there is EXACOG and we want to introduce, to see if we can bring in fellowships. People can stay where they are as long as they have a supervisor locally. Without having to come to Kampala, the university, they can stay where they are and do a particular program and come and get examined at like COSEX and other things at a center and go back and do their things. But also now, you realize that many of the general referral hospitals now have specialists, senior consultant, who can actually train their colleagues from there without them having to move towards the centers. Centers are meaning these big places like Imbarara. But also, as I've told you, advocate, and we want to know who our members are. If Dr. Sana is saying he's a gynecologist, is it true? Where is he located? Okay? Where can we find him? Where can we refer? We need to know. Otherwise, you may find somebody is highly skilled, but no one knows about him. So people will suffer, including ourselves as referrals. Then, of course, we want to promote super specialization. But this, I think the academia and other people who are qualified in that should follow up. Then, of course, we want quality improvement. And a lot of quality improvement is around mentorship. Some of you will live here and struggle because you have no mentorship. You don't have people to hold your hand and show you the way. Okay? So a mentor has gone through those steps. He has failed, succeeded. So he knows the shorter way. That's how some people will succeed. And of course, partnerships. You should never pass down, you should never send away a potential partner. Even if they are boring, you just say, okay, come and we talk. But listen to them, because it's in those partnerships that you will tend to grow. I've seen people sending away drug representatives. those guys may change your life. Or they may open for you opportunities. I've seen people harassing NGO people. Those guys, you have to partner. And as a specialist, it is your role to maintain the partnerships, always. And I think those of you who have been reading my papers, I'm talking about the senior consultants, those guys should actually maintain these things. Then, of course, the universities and training institutions. Then research, research, research. A lot of our work as AOG depends on grant writing, and I think we are privileged to have somebody who does a lot of grant writings at the center, so it sustains us. But we also want the regions chapters have a lot of grant writing there. And AOG has been paying a lot of money, not paying a lot of money, has been doing a lot of grant writing training. Okay? Because we want our members, wherever they are, to actually write them. You're hearing Guru now. Guru is not shining by mistake, by the way, in terms of writing grants and getting those small, small things. It is because of the capacity that AOGU has put to train those people. And they commonly keep coming for some reason. And now you're seeing the fruits of them, what they are doing. The seed grants, we want Mbarara to be the hub. Some of the grants we give to SHOs are coming from people who are trained in grant writing. They can write grants and then provide those seed grants. So this is our agenda, and we want to take over in all these areas. So if it is in Mbarara, take over the research, take over the NGOs, take over, make sure you've taken over. Then, of course, advocacy, advocacy, advocacy. Sometimes we fight over advocacy issues, but people must listen to us. You find a politician, advocate. You find this one, advocate. If you don't know how to advocate, Dr. Kaye is the expert in advocacy training. He can, I think, make a training for Mbarara just to learn advocacy. You cannot go anywhere without advocacy. Now, one of the things I've had in medical schools, MMed programs, when they are admitting people, they want to experience. You must have done 2 years and you must be in a hospital. But the obstetrician can go in any area. So you may find somebody has been in the politics. He can learn to do a season MMed, but you want his advocacy skills to speak out. If you're only trained clinicians, we are dead, because we shall hide there and not say much. Okay. So, who is the obstetrician and gynecologist? As a professional. So, a profession means people who do the similar things. And for you to be an obstetrician, you must have an MMed or an equivalent. And because of that MMed and its equivalent, you must conform to particular ethics. Our ethics may be slightly different from the surgeons. You know that. I should not see you doing a hernia in Mbarara. Even if you're trained to do it as an obstetrician. Me, if they came to me and said there's a problem, I'll say negligence. It's not your scope because there is a surgeon there. So there's a code of conduct that we must maintain. And that committee up there will be in charge of making that code of conduct for obstetricians. So we have as doctors, but there must be a code of conduct that we have. So professionalism is behavior and the way we conduct ourselves with the public and other members. So because we're in a business environment, we must conform to certain behaviors. So I should not be dirty. I should not be smearing. I should not be abusive. I should not be as a gynecologist because I'm a professional. So I'm glad to see that many of our members here are in the process of professionalizing. Somebody spoke about UMA saying specialists are complaining about the behavior of new specialists. It is because we have failed as professionals. They are looking at us to guide them. But if I am the one dodging duty, I am abusive to patients, I don't write notes, I don't even attend audit, what do I expect the next guy to do? So when people find people who are serious, they will then tend to also become serious because they have followed the right path. When you call Dr. Waswa in the night, he will likely come. Not because he likes it, but because he's a professional. He knows when I pick that phone call, I have taken the decision to respond. I may come and quarrel, but I've come on site. So, profession. Then, of course, the conduct is our behavior. Then there is something called humanism. Of course, I planned to be a neurosurgeon because I thought there was enough money there. But what is the reason you are in obstetrics? Is it for the money? Is it for the service? Is it, why are you there? What drives you? If you're driven by money, at least be competent. But if you have a passion for it, then at least grow the discipline. So what is motivating you to be an obstetrician? Some of you may have come for different reasons, but also we must be culturally sensitive. I am not a Munyankole. But if I come and work in Ankole, the culture is different from Buganda. So I must be culturally sensitive in the way I do my work. And I may have to respond differently when I am in that culture compared to Guru, because the cultures are different. So as obstetricians, we must be mindful of that. So there is a charter for professionals. One of them is you must commit to competence. That's number one. So if you are trained in 1985, for God's sake, things have moved on. Don't stay there. Make sure that you is a minimum level, and that minimum level keeps shifting. Okay? I am not competent in fertility, and I accept it. So I can refer to the SHO, who is more competent, because I don't update myself in that field, and I don't do that work anyway. You get it? So the minimum level of skill for the fertility people has kept shifting because they are updating themselves. 2, number 7, you must update yourself in your area of specialization. I'm a gynecologist. If all my CPDs are PPH, this, but for God's sake, my clients are cancer patients. So at least most of my CPD must be in gynecology, most of it. I may still do some obstetrics, but because I'm a super specialist, I must do that. Then, of course, why I'm here also is that as members of a profession, we must meet licensure. We must subscribe to our bodies and hold them accountable and ask them to support us in all ways. So unless you subscribe and you're based in the body, you'll likely not survive. Part of our attributes, accountability. And that's where I normally write something about on NASMEC. Why are the obstetricians not accountable? How does somebody die in your hospital and you don't know? And when they ask you, you say, that is not my work, and you are the senior consultant. May I also bring, I'm like, there must be something wrong that is not connected. So we must be accountable. Why isn't the lecturer coming? Why do I call Dr. Munjinya and it doesn't show up? Why do I? But also importance is self-regulation. If he does something wrong, I should tell him that is not right for our profession, regulation. Otherwise things go bad. And the council is saying, you obstetricians, the biggest number of cases are in obstetrics, and you know the bad fruit, so deal with them. Then of course, I like number 6 because look the part. When the first person, I think, not the first person, Dr. the MPH person spoke about herself. She looks the part. So if I am shabby, nobody will believe you need to be obstetrician. If I am falling in the gutters, so now look, let's look at that guy there. He looks like an obstetrician. So I will most likely even pay him more if he tells me 100,000. But if I am in Sapatu, what? Will be like, this guy must be a quack. So look the part, because it is a professional attribute to look the part. I have learned to shave sometimes because I must look the part. Okay. So where is the obstetrician? Where are they found? Most of us are in clinical practice. But we have colleagues who have gone into administration. Okay? We have colleagues who have gone into academia. We have colleagues who are in policy. And we have colleagues who are researchers. So sometimes we mix clinical practice with academia like that. But those are the 5 areas where the obstetricians are. But for the case of Uganda, most of us are supporting the clinical practice. So LGU, a lot of our work is supporting the clinical practice. Now, this is an issue I need to, since I have young colleagues here, who is an expert, who is experienced. I don't like the word experience from my point of view. I prefer the expert, because the expert is the source of reliable skill. So I mean, you may be younger than me in the profession, but you're the expert in that area, and I must accept. I won't say, I'm the one who taught you. So, but you're the one doing the Eurogyne. So I should refer to you because you're the reliable source of skill, and we must accept it as colleagues. So if you're senior in what? Okay? So make sure you are an expert first, and then you become experienced in doing the right thing. So what are we advocating for? Those of you saw the paper I wrote, Regional Referral Hospital. One of the arguments we had on the chat one time was, and it actually pained me, that a senior consultant was arguing against. And I'm like, but you know, you're doing the work of a health center for people are referring you to do cesarean section at regional referral because the other structures have failed to function. Those are there. But regional referral, we should have maternal fetal medicine there. Okay? Proper, we should have general obstetrics. Then we should have gynecology, oncology, urogyne, general gyne, reproductive medicine. People are referring for those services, not referring for transfusion. So, Mbarara as a center and KIU as a center, I think we need to go into this model. So the minimum number of people I have to see in a unit of obs and gyne is about 7 specialists, each one adding value. If you're all doing cesarean section, it doesn't add value because the SHO can do Caesar. So somebody must teach the SHO how to do VVFs, pelvic perineal repairs. You get it? They must learn how to do some cancer surgeries. They must learn how to do fertility. Otherwise, we are struggling because many of our systems are based on obstetrics. So that's the structure we're advocating for. Now, under each discipline, MFM, general gyne, this is what we would want to see. We would want to see a senior consultant, MFM specialist at Mbarara. We want to see a senior consultant, urogyne, senior consultant, reproductive medicine. And under each arm, from HR, a lot of my training is on HR really. A senior consultant should supervise 2 consultants. Each consultant should supervise 2 special grades. Each special grade should supervise. So the minimum structure under MFM should have about 14 people in a place like Mbarara. Because I think soon you'll be at NRH level. So I think we need to look at our structures and make sure that our structures are done well. So I would like to end by saying that as AOGU, we would like to have strong regional chapters. We would like our young, not even the young, all obstetricians to fall in line, become professional. We would like our young obstetricians to get mentorship. Those of you who are seeing Dr. Kaye here, you better get his number and start stressing him a bit. They may change your lives, but also they may guide you to where you want to go. Then we have colleagues who are in government. Sometimes they fear to speak for some reason. We can speak for you and say, hey, Mbarara is like this. Hey. Now, we took a decision to support the industry action because we must look at the part where our obstetricians not paid well. A good number of our colleagues are almost entering retirement. Okay? So if I retire on a salary of 5.4 million, then I think my package is about 2 million, I think. Not so. About half per month. So I'm coming from 5 to 2. But if I retire at a package of 20 million, then I'll get about 8, 9 per month as my retirement package monthly. So I can survive. But I have served the nation, then I cannot survive. That's why we're finding people, Musana is trying to do a Caesar at night. Then even Dr. Wasa is also seated waiting also on the next desk waiting to also do the Caesar. Yet actually should be doing a much higher level. So I think our members must be paid. And I'm hoping Dr. Masembe is listening that we should promote our businesses. So refer all fertility patients to Neo Care if there is no service in Mbarara Hospital. Refer all patients of Urogyne to Dr. Kayondo and group so that they also build their career, but also serve the patients better. Then the SHOs, please get mentors. As I keep telling you, when I go to Mulago, now Zambia has no more mentors for me. When I'm at somebody, they tell me, but you're very senior. And I'm like, I'm not yet there. Means I have to look for Dr. Waswa, I have to look for Nachimulini Mulago, so that I can also sort of continue to grow to their level. So learn to network. And we should know you. I know her because I had her talk and I'm like, so if they ask me in Barara, I'll be like, that doctor, that side. And I'll ask, now I know Dr. Mugenyi because I met him before, but also he's an author. We have two authors in this room. Dr. Kaye, who has authored several books, and Dr. Mugenyi, I think he has begun his journey. These are landmarks, by the way. Now, I'm proud to hear that we have members from other countries in KIU and in Barara. We have international members as part of LGU, and we can support you. We do a lot of work with FIGO, and we'd like FIGO to penetrate places like in Barara, Gulu, so that you can do work directly with them. We have a lot of work with WHO. We want you to actually sort of. Now, to my colleagues in private sectors, I think most of us are in private sector. That's the reality. Many of you who are training here are going to end up in private sector. There are no government jobs. So we must make the work. And that's why I commend my business owner there and others. Let us make our own work. Make a partnership, build a franchise in Imbarara. People should not come to Kampala for small things. So I'd like to end here. I'd like to thank Dr. Kaye, who runs the Secretariat and has kept us moving. A lot of the work that we do is headed by him, but also written by him. That's just the reality of the way. And we'd like more members to come to LGU to continue to support. Don't support only yourself. Make sure you support the next guy, the next guy, the next guy. A lot of our growth has been because of somebody else doing something and pulling us along. Then we can also make work for the next person. So I'd like to thank you. I am really proud to be in Imbarara, and I think this has been the biggest number of young people I have seen in one room, obstetricians. Young, below 50 or somewhere there. And I believe that, and I'd like to thank KIU, by the way, since they are here. People in campus say KIU trains poor graduates. It is not true. As a teacher and a trainer for internship, and I've had a chance to interface with all. Okay? And their work is good, but also in improving access, it is likely that this trainer, the medical officers, the specialists who are trained like in Imbarara will most likely stay on this side of town. So it means they increase access to services. But also wherever they go, services improve. Even in the north, there are so many KIU graduates, and they're doing good work. There are so many people from Imbarara I met, it's called Opa, Jimmy? OP. And OP is really, and I'm like, if only he gets a mentor, he will likely do good things. Yeah? So we appreciate the work you do as training institutions. We hope that you can get mentored. If you have no mentors, Dr. Kaya is there. You can harass him. I hope he would accept. If you want to learn to talk, you want to learn to write grants, if you want to learn to do good things, Dr. Kaya is still there as the ED of the Hope. Thank you very much.
Thank you very much, Dr. Musana. Another hand clap for our president. That second one is more presidential. The first one, it's like as if you had been clapping for me. So, Dr. Musana, the first time I talked to him, I realized that he had a vision of the younger gynecologists getting involved in Awogu. Previously, Awogu meant Dr. Waswa, Professor Kaye, those who know Professor Frank Kaharuza, the DVC of KIU. It meant the senior citizens. But there's a new vision. There's a vision for fresh blood to come in and start from where our senior colleagues had stopped. And we want to commend you, Dr. Musana, and on behalf of the members of the Western region, I promise you that we shall be vibrant. I promise as I look at you, because we are going to do this, we shall be a vibrant part of the association. We are all going to subscribe. Can I have some hands raised to that? We are all going to subscribe. Subscription fee is, let me get, is membership fee. The initial membership fee is 160,000. And we have an account for Awogu that you can pay to. We also have a mobile money number in case it will be difficult for you. But I'm also available, and later on we are going to elect a committee so that I stop doing the work alone. One of the positions is treasurer. There will be a treasurer to receive the money. So we can begin with the membership fee, and then the subscription fee is 100,000, Dr. Musana. Membership is 100, sorry, of 160,000, 160,000, 50,000, and the membership for SHOs is 100,000. There's 100,000. That is a correction. I hope it is clear. Membership is 100,000 for everyone who wants to join, and the 160 is subscription every year. So I can see the 260 already coming very soon. I also encourage those who have not registered with Dr. Fiona to register so that our books are clear at the end. Some of you joined us after breakfast, but we had the breakfast a bit late, and we think we can do a few more things and then just break off for lunch at once, so that we don't have that delay of going and then coming back. We were supposed to have a Q&A session, and I think it connects very well with the presentation Dr. Musana had made. So at this moment, I would like Professor Kaye to just say a word or two, and then we can ask all the questions about Awogu. Professor Kaye has been in Awogu for some time. And I think he knows the association in and out. Yes. So, Professor, just a word or two, and then.
Where I am. Thank you very much for the time you have dedicated to come to this meeting. We are very grateful, and it shows the solidarity among the members and residents in this region. I was asked to make a few remarks, but I would have preferred if I'm directly answering to some questions. But before that, I would like to thank Professor Ngonzi for his talk on mentorship. And I would like to, some of you may have heard about a mentor's manual, which gives guidance on mentorship relationships. It's widely available. If you put, it was developed by JCRC at a time when I was one of them as their training coordinator. It's widely available, free. If you put in Google, Mentor's Manual for Health Sciences Training, you'll get a free copy, which you can share with your mentees and also with your mentors. Because some of the things which Professor Ngonzi was talking about in that manual. I've already shared it on the AOG forum and on any other group forum on which I am a member. I've already shared it in a few minutes ago. The other thing I wanted to say is to thank the President for his elaboration of his vision of what he wants AOG to be in the near future. We would like to make the association more relevant to members and the associate members in the region, especially in the regions. And I would like to thank him for his efforts to see that actually this is taking place. He has been to Kulu, has been to Arua, has been to Hoima, and now here, and one time they were in Mbale. So this really is walking the talk of making sure that the regions and the members in the regions are strong and working together to ensure that we are the leaders in quality reproductive health. And like he emphasized, we have 5 main areas which include capacity building or education, research, service delivery, advocacy, and partnerships. This is one example of partnerships where Bharat BSV has sponsored this activity. It's a very good example how you can make friendships with people who can identify how they mutually benefit from the relationship with you and can fund some of your activities. In the area of advocacy, yes, we have been mainly trying to advocate for improved service delivery, improved welfare of the healthcare providers, and especially the members. And we don't have much activity because we don't directly provide services as AOGU, but we contribute in many areas. For example, in the development of the patient management guidelines, we contributed significantly, and one of our projects funded a significant part of formation of the development of those guidelines. We also have been engaging the Ministry of Health in updating the scope of practice and also the job description of many health workers, so that these are aligned with the competences of the different healthcare providers. We have also engaged health professional training institutions, the tutors, try to see that many issues in reproductive health which were lacking in the curriculum, some of these curricula are older than 10 years, yet they are supposed to have updates which you already find in the field, so that we have engaged them. And as you know, when it comes to curricula, we have engaged some of the residents from this region. When it comes to curricula, there is a good opportunity that even though the curriculum document hasn't changed, there is a taught curriculum. A taught curriculum has everything that tutors find relevant, even if it's not included in the written document, because the written document may be old. And also there is the hidden curriculum, what the tutors and the students must see and learn. Sometimes that's self-directed learning, if it's something that is relevant, so that it's expected you to know about COVID. How many have read a textbook on COVID? Probably they are coming up. On guidelines on management of COVID. They are not there. But all of you know about COVID. Even the things of tomorrow, by tomorrow you'll know. They are not in any textbook. They are not on your curriculum, but you are supposed to know them. And that's what the taught curriculum is. And also the hidden curriculum, in that there are some things expected a student or a healthcare providers to have updates on, even if they are not in the curriculum. As long as they are relevant, they must be known. So some of these in our advocacy, we ensure that once we mention these to the tutors, then they can include them in the curriculum. In the areas of training, he has said, the President has said that we would like to strengthen the capacity of members. I would like to let you know that it's only COVID that stopped us, but we are ready to have some training to members and non-members. The plan was to make training free to members who have subscribed. AOGU has trainers and training manuals, facilitate and training manuals in many areas. For example, scientific writing, grant writing, data management, monitoring and evaluation, fundraising, so many different areas which many of you would find that they are useful. Our plan is to make sure that those members who are subscribed, when we arrange the training, they don't pay anything extra. And those are some of the benefits we think would attract many people to feel that they should belong, and actually they have to belong to the association, so that we try to make it relevant to them. So those are some of the few things I wanted to say, but maybe just say that as we have always had, we are planning to have our new conference sometime in October. We shall confirm to you the dates. Please prepare some abstracts for presentations for the conference. They don't necessarily have to be research. You know, in the current paradigm of knowledge and knowledge generation, knowledge is not only generated from research. That is primary, where you set out from scientific inquiry, these are the steps, these are the methods. It may be a project, and you tell us how you have managed your project. It may be your vision. You share with us your vision, and we may learn about it. Some of you may have heard about somebody who's very well known, Einstein. I think you may have heard about that man. He wrote about the principles which people use to build rockets. And up to now, he never threw in one. But some of the principles they are following were his. And actually, he had not been trained. Some of those were ideas he would just speak. But people found them relevant and would put them in practice and find that actually his thinking was right. Many of you are as good. In that many of the ideas you have are very novel. They can help others who probably have more resources and more practical oriented, and they can put this in practice. And at the end of the day, you find that we develop. So you shouldn't restrict yourself to only research. It may be a project work. It may be your experience, which you can share with us, with others, so that there is what is currently known as mutual learning. You identify areas of learning, areas which are new and which can be shared, so that everybody learns from your experiences. So these are some of the few things I wanted to share. Thank you very much.
Any questions? Okay, I see.
We are lagging behind in this area, but I'm sure many of you would like to have this training. The vision of this is that you train from where we are. For example, Dr. Banya has been in Kisizi for more than 10 years. You can train from there or train somebody from Kabale, and they just meet once in a while. There is a curriculum, somebody trains themselves, but they are mentored on job or mentored periodically. And at the end of 4 years, which you can spend in Uganda Hospital as a specialist, you find that you get another fellowship. Now, the good thing is that National Council of Higher Education, National Council of Higher Education in Uganda, and Medical Council have approved the curricula for the fellowships. And they have also approved the ideas of the fellowships. They are both professional and academic in that they can be accredited by the various health professional institutions. So you may find that actually you hit several birds by one stone. In our time, we used to fear going to up-country places. But if they tell you that now you are, like our president was saying, that we would want, his vision is to see specialists at health center 4. If you are taken to Wizwera as a specialist, you may spend there 4 years. At the end of 4 years, with this kind of arrangement, you come out, super specialized with an qualification that we recognize professionally and academically. And I don't think anybody would fear going to Wizwera or to Bukuku Health Center or to Ngonzi or to any other health center. I mean, the objective is to make sure that even as you go, you sacrifice to go up country, to provide a service, you also grow professionally. So that these fellowships are, you don't need to always be in a class. Many of you remember about COVID experience has made it, made people realize that you don't need to be a class always to learn. You can have a lot of sharing and learning that can occur without walls. You sit under a tree, and then you communicate with your mentor, you learn from each other, you go to your hospital or health center, you find a difficult procedure, you communicate, you learn how to solve it. So these mentorships and fellowships, I think we are going to see how even Uganda starts this, so that many people, especially those in rural areas, which are taken as rural areas or up-country areas, are not left behind in professional and academic development. Thank you.
Thank you very much, Professor Kaye. Again, on the issue of subscription, I know there's an account and a mobile money number, but for our solidarity as the Western region, I think it would be good if we can pull all our subscriptions and then we send them to the Secretariat as a block to show them that the region is rising up. And then all the receipting will be, our role as the leaders will be to get the necessary receipts. Yes, Dr. Musan.
The purpose of the subscription is to support AOGU activities. A good chunk of that money actually comes back to the region to support CPD and other activities. Some of the money that is used to sponsor many of these meets is actually from AOGU, the center. But we'd like that when the region subscribe, a good chunk of that money actually goes back to support the regional activities for that AOGU chapter. Then AOGU as the center, through grants and other things, can just top up on some of those things. Because like CPD, if you remember, we are trying to make a collaboration with an online platform for our members to access CPD content, which is accredited. When the council and AOGU sign an MOU, ideally you will not get licensed unless you have a letter accrediting all your CPDs from AOGU. And that can only be tracked from online and through the region. But also, if I'm an obstetrician, and I'm going to give a CPD, I expect that within the region, there must be a team which accredits the content in my CPD. Because I may be training people 1990 stuff, when we are in 2022. So the region can take care of that locally with support from the center. Because if I'm training Urogyne, then I'm sure that there's a team here which can look at the code and say, this is appropriate and this is an update, as opposed to anybody just doing whatever they want to do.
Yes, thank you, Dr. Musana. And I'd like to report that part of facilitation for this meeting came from AOGU. It came from the Secretariat. So those of you who came from outside Mbarara, when you get a small transport refund, it is not from my pocket. It is from the Secretariat. So if the Secretariat has done that before we subscribe, how about when we subscribe? It means we shall have a lot more support and more of these activities. I cannot overemphasize that. Dr. Fiona is seated at the desk there. If your subscription is ready, she can receive it. We promise that we shall get you a receipt from the Secretariat showing that the money reached there. We have a number of regions represented here today. We have Uncle has Mbarara here and other districts, but where there's a dense population of our members is in Ishaka. And KIU, International University Western Campus, is well represented. If you're from KIU, can you just wave to us? It's well represented by a team that is headed by the Dean, Faculty of Medicine, Dr. Maxwell. Towards the end, he will come and give us a closing remarks in about 5 minutes. And then we have people from, I introduced the ones from Kabale. We also have people from Kisizi. Now, that is also Chigezi, but we have gynecologists from Kisizi. Dr. Banya was introduced, and Dr. Henry, the medical superintendent. We are glad to have you. Dr. Henry had been on the program to make some remarks. I know our time has gone. I'd like him to just say hello, and then we can see how to move.
I'm the medical superintendent, Chis's Hospital. I'm very glad to be here. I want to commend Dr. Musana for what you've done, and I want to say that this has been long overdue. You've now given us reason to belong. And you shouldn't overemphasize. We are going to subscribe, we are going to become members, and we are going to support this association. It's been long overdue, but thank you for coming through. I think the future has a very, very, very big space for us to occupy. And I want to rally all of us to come in and join. We have to make our presence felt as obstetricians in the Western region, but also in Uganda. So let us rally together. Let us celebrate every success story that one of us makes, but also let us give service to the people. It's good to see that Dean being an obstetrician, both KIU and Mbarara. I want to tell you that in Chisiz, where I hail from, it's an obstetrician seated on top, but also the deputy medical director is an obstetrician. It's not that we don't have other specialties, but it shows that obstetricians are actually, what he called smart. And let us maintain that. To my brothers and sisters who are still in school, there is a lot of space at the top. Don't fear, come up, and thank you for the strategies that you've told us that you want to occupy everyone. So let us not be scared, let us come up. Thank you very much.
Thank you very much, Dr. Lukabwe. You've heard for yourself. We shall keep celebrating these successes. I know one of us very soon will become the medical director of Fort Portal Regional Referral Hospital. Dr. Semju, can you wave to the people? Yes, when that happens, we shall celebrate again as a Ogu Western Uganda. But there's already a success story that has a success that has happened, and a team that is led by Dr. Masembe at NeoCare successfully conducted IVF and actually delivered the baby. I would like to invite him to share more about that as we celebrate as a region.
Thanks so much. Protocol observed. Our leaders of AUGO, our parents in the specialty, good afternoon or good evening. So I'm Dr. Masembe Cesario. I'm a child of Mbarara University of Science and Technology. Most of my teachers are here. And I'm glad that we are taking forward the seed that our fathers are planting in us, and the fruits are bearing. We set out 6 years ago to venture into fertility medicine. After my training at MAST, I went to McMaster, where I spent close to a year studying reproductive endocrinology and infertility. I remember after reaching here, Dr. Mujenyi organized a meeting like this, and in this same place, for me to share about the fertility technologies. I did that. By that time, all the technologies were still theoretical, and we couldn't believe we can have an IVF baby here. So, So we have a fertility center named NeoCare Clinic and Fertility Center located in town here in Mbarara. Okay. Good. So we are a team of clinicians, that is fertility specialists. We have a lab team where we have embryologists and andrologists, then a nursing team that coordinates patients and treatments, and a theater team where we do procedures from. And currently, we are the only people offering ART. ART is assisted reproductive technology. We started as a Class A center where we were able to do diagnostics, controlled ovarian stimulation, cycle monitoring, sperm wash, and intrauterine insemination. And we succeeded in that. We have innumerable babies. But we kept with a need for IVF. And at that time, we used to stimulate patients and carry them to Kampala. We had partnerships with Paragon and Neogenesis and other fertility centers where we used to do lab work. And our need remained lab work until when we had our own lab. So in 2020 Feb, our IVF lab was installed and activated. Unfortunately, immediately after that, our first lockdown started. We had about 10 patients who had started stimulation, and we had to cancel that cycle. And we closed the lab for 1.5 years from then. 2021 in April, we embarked on cycles, and our first batch had 6 patients. We had 100% fertilization and cleavage, and we only achieved 1 pregnancy, which was a chemical pregnancy, and the rest failed. It was so painful, we almost closed the lab. We continued, our second cycle was in June 2021 with 8 patients. We had 2 clinical pregnancies, both were twins, and all were miscarried, 1 at 9 weeks and 13 weeks. Still, this was a huge blow, and we felt like backing down. And our third cycle was in September, where we had 8 patients, 4 clinical pregnancies, and we have 2 live births, 1 girl, 1 boy. Currently, we published about 1. And from October, we are able to do monthly batches of 8 patients, and we have many ongoing pregnancies, and our success rate is so far 30 to 40%, which rhymes with global success rates for IVF. And for conceptions from other simple technologies like ovulation induction, cycle monitoring, IUI, innumerable. So that is the simple story of how we have evolved, and this summarizes the success rates just to emphasize and have a benchmark. So we are not doing bad from start. So 38.6 is the general success rate for those below 35 years, and we know as women age up, success rate goes down. Our current scope of work, we are able to do all fertility diagnostics, lab and imaging. We can do controlled ovarian hyperstimulation, ovulation induction and timed intercourse, ovulation induction and artificial insemination, and then assisted reproductive techniques, including conventional IVF and intracytoplasmic sperm injection. We are also able to cryopreserve gametes, that is sperms and eggs, and we can also preserve embryos. We also run gamete donation programs, that is egg donor, sperm donor programs for those patients in need. And we have many successes through those donations. Maybe in summary, these are the steps of IVF. I may not go through them because of time. This summarizes the stimulation and monitoring. We have protocols, the short and long. I will share these. This is the image of an ovary at the end of night stimulation. We usually want over 15 eggs. And this is what we see in the lab. First day on fertilization, we have 2 pronuclei and 2 parabodies, and that is the first success level. And then cell division starts until when we have day 3 embryos or day 5 embryos for transfer. This summarizes how we retrieve embryos through a needle and ultrasound scan and a suction pump. And again, this is a summary. This is a summary of our theater where we conduct the retrievals and transfers of embryos. This is how we do embryo transfer through special catheters. And under ultrasound scan, you can see a catheter and an embryo being implanted under direct vision. This is the lab where we have a workstation. Again, a workstation, then the X microscope for sperm injection. And this is work under the... Now we have cryo tanks with liquid nitrogen. Embryos can be kept here up to 10 years. And we know our causes of infertility, tubal factors, and male factors. This is about 60%, and all these need IVF. And this is emphasize the need of IVF in treatment of our infertility. And so many other indications. I think this brings me to the end. Thank you.
Thank you very much, Dr. Masembe. You know, it's very empowering to see someone you know doing big things. Things which you used to hear being done in far places. You see them being done near you and by people you know, people you have on, you can call at 2 a.m. for example, and they pick up. That is one of the importances of this association. We are about to come to the end. We have 2 or 3 parts remaining. They're all very brief. One is the election of the committee to run our region. Like I said, I've been doing the work alone ever since I was elected at the last AGM of Awogu. But I think it's time to get some help as we work towards becoming stronger. So the other part is, again, a very brief talk on seniors and juniors supporting each other. We shall then have a 5-minute closing remark from the Dean, KIU, Kampala International University, Faculty of Medicine, Western Campus. So there are 2 people who are going to lead us into those last 2-3 bits. Dr. Mjeni will help us as a returning officer for the election of the committee. And then he will go ahead, again very briefly, because we've been here for some time, he will go ahead and make a brief talk on how we can work together across generations. And then after that, the Dean will give closing remarks, and we'll be done with the meeting and go for lunch. Thank you very much.
Yes, thank you, Dr. Kajabwangu. I'm told that Kajabwangu means precipitate labor. So here he is leading us in a program in a very, very, very short time. Dr. Musana is laughing at that statement, but I think it is correct. I'm going to be Kajabwangu in these 2 sessions. I'll be very quick and brief. I am going to introduce the positions that our Western chapter president thinks are going to be helpful to run the affairs of our chapter. We currently don't have a functional constitution, but we shall rhyme with the constitution of Awogu. We may not follow it today to the dot for elections, but we believe that this committee needs a general secretary. Have you written that one down? General what? Then we shall need a treasurer. Then publicity secretary. Worokoso. You look for someone who can make the loudest noise. Treasurer is someone to keep our money. General secretary is someone to keep our records, to keep our minutes, plan for us, and help the president. We shall need coordinators. And the coordinators are going to be according to the regions. Ankole, okay, this is Western. And West starts from Hoima, those new districts around there. You know Western Uganda. There is Chigezi region. So we shall need a coordinator from Chigezi. So those people from Chisizi, if you are 1, you are unopposed. If you are 2, we vote. If you are 3, someone becomes a loser. I saw Dr. Onesimus here. He's from Rukunjiri. The only obstetrician gynecologist currently at a health center for, I hope I'm right. So Chigezi region shall have 1 coordinator. Rwenzori, if you are around Kazinga, Chano, Kasese, Hoi, Fort Poto, I think, I don't know whether Chegegwa is. Is it also with you? Mami, which region are you? Stagwenda. Stagwenda, I think you are part of Rwenzori. Don't join us. And then the Ankole region. So there are 3 coordinators. And then we shall get representatives for associate members. And these are going to be people from the training institutions which have residence training programs in the region. So Kabale University, KIU, and MUST. And these, we prefer to have people who are in their first year of practice so that they can be on the committee for at least 3 years. If we don't have a first year, second year. If we don't have a second year, the third year will be there, but we'll nominate someone when you leave that position. Or you can stay with it. I don't know, the chair will guide as we go on. Then finally, an elder. Now, after talking about the elder and introducing the structure of the committee, I am going to proceed with my talk. But as I talk, I will expect that you will make WhatsApp, nominations so that by the time we are ending, we already have the committee. I will call for nominations. We go from one post to another to the other until the end. If we get more than one, we vote. Okay? Good. Without wasting time, I'm Dr. Godfrey. According to his definition, I think I'm a senior, because he said a senior is at least more than 45 years. I want to disagree. One time, you guys know that I was below 40, and I was supervising one of my students who was above 45. Okay? My nickname these days is Uncle. These guys call me Uncle for their own reasons which I don't know. But that student I was calling Uncle. Okay? So, the thing of age is very, very, very important. And I want to start with that. There is an African saying, I think it is Igbo, Nigeria. They say that what an old man sees while sitting, a young man cannot see while standing. The old man will see while sitting down, but you will not see while standing. You will actually need sometimes to climb on the shoulders of a sitting old man in order for you to see what he sees while standing. I do not want to give further description on that, but let us utilize these senior citizens to achieve our goals. See through and get a window and pick a leaf. Does that make sense? Okay? What is in my pocket today? Okay. Mr. President, you're the most eloquent person we have here. I have written you a cheat or a letter. It's a love story. You can read it for us.
So the cheat reads junior, underlined, I think for emphasis. For or denoting young or young people. The second bullet is low or lower in rank or status.
Did you get them properly? Read them again.
What is a junior? That's junior. It is for or denoting young or young people. The second bullet is low or lower in rank or status.
Why did I ask a young person to read this? There was nothing to do with age. And this is Oxford Dictionary definition of a junior person. It is low or low rank, but they did not say young or old. You can be there, you are 33, you have your PhD, you are appointed an associate professor in a department. you are a senior. But you can also be 55. Yes? You did your struggles. You have passed through a very thin and thick line. And at a tender age of 55, you have become a medical officer. Dr. Kayondo is not here, but he usually introduces his residents as medical superintendent, director of health service. But you have come for your name made. Eh? So he tells you to leave your titles there. Today you are a resident. And all protocol observed in first year. Okay? You are supposed, even if you have done 1,001 cesarean sections as a medical officer, today you are a learner. Dr. Wasa says, empty your cup, remove all your titles, become a junior and start the learning curve. Dr. Banya, cheat is there.
Senior of or for older or more experienced people. And the second bullet, high or higher in rank or status. Third bullet, specific number years in a field or position.
Thank you. I think my work is finished. At least in the element of defining a senior, there is age. Did you notice that? Of older, it is very difficult for someone to be 18 and is a senior citizen. No, there is an element of age. And that is why things are stratified the way they get stratified. I don't want to dwell a lot of time on this. A lot has been said in the morning, mentorship and talks and talks and talks. But I want to add one thing. You cannot give a lift to someone who is not on the road. You cannot give a what? To someone who is not on the what? On the road. If you are in a footpath, the only thing you can get is someone, in my language you could call it katera rume. The go-between is the thing, but katera rume is this person who leads you when you're going for marriage is katera rume. Ideally you're clearing the dew in the grass, in the footpath. But let me tell you, you will never get a lift. Be it of a bicycle, boda, or a car. You must be on the road in order for you to get a lift. So my dear juniors, prepare yourself out of the footpath and get in the road. This mentorship song that they have been talking about, you cannot mentor someone in a footpath. So get out of the footpath, go to the road, and then the rest will be added on to you. My topic was, how do seniors and juniors work together? Me, I'm lucky. I've never looked for a job. I've created the jobs that I have always worked. As a medical student, before a medical student, I was in senior 6 vacation. I was somewhere as a licensed teacher of a primary school near a hospital, and I met Dr. Waswa. Senior 6 vacation. I met him like 3 times before I came to the university. He was coming for outreaches, so I managed to meet him. I was staying in a boys' quarter in a house in a hospital for the doctors, and whenever he come, they would accommodate him in that. That is when my road started, I think. I got out of the footpath. Then my results came. I said, oh, they have called me to Mbarara. I say, oh, from now on, you're my son. You get the story? Okay? Get out there and move. So, of course, I finished internship. I did medicine. I did internal medicine. I did OBG. I remembered, at the end of it all, you're saying, what do I do? Where do I go? Then I recalled one time I was in internship in Obs-Gyn, and I did 8 cesarean sections. One was multiple pregnancy. So 17 lives, 8 mothers and 9 babies. I remembered I was in internal medicine. One night I admitted 8 patients, did everything. By 11 p.m. I went to sleep. Around 6:30 I came back to prepare for what they called post-take, and you know post-take, those who have been in internal medicine in Mbarara. I looked for my patients, I couldn't see. 5 had died between 11 and 6 a.m. and I only had mortalities. Then it was that scenario made me change my mind, that I should go the other side in OBG. And by the time I finished internship in internal medicine, when I had done OBG first, my senior then was going out of the country. Then our seniors used to do call for 1 week, then another one comes on. This senior was going away, he didn't have coverage. I received a call from him asking me, since we have finished internship, actually it was not a call, it was a written letter, copied to the medical superintendent of a regional referral hospital then, asking him to prolong my stay in the interns hostel, and then I cover his duties while he is away. That was my first feeling of being a consultant, because I was covering a consultant. And by the time I finished that, covering him, I already had my appointment letter as assistant lecturer. That's why I never looked for a job. The private practice I work, I wrote a proposal, worked on it, built a building, and that's Divine Mercy Hospital. I never looked for a job there. How ready are you to market yourself in the hands of seniors? Because most of the opportunities are in the hands of seniors. Now, life is a journey and it's not a destination. Most of the juniors want to leave the destination. Yeah, Dr. Mujenyi has this car, I also want to drive it. Who told you? Oh, he gets this amount of money, I also want to get it. First finish the millet that is in your basket before you look at the one in the other person's basket. You get it? I'm not saying you shouldn't get money. Please go and get money. And there is plenty. Each of us has a potential of getting the money that they need. But it comes in steps. I had never listened and known Dr. Musana's story. I am lucky today. This is the second time I'm listening to you physically, but I'm impressed. Your story is a story that we should put in another book. Now that I'm a book writer. The first time, I think we were in the dissemination conference in Lakeview, and you mentioned the stratification of cadres in Augo, and you related it in the Ministry of Health structure and in the university structure. There were seniors and juniors with, the positions in between. And you corresponded each of them with their duties or expectation in output. I remember I expected it would be in your presentation, but today it wasn't. It was in a green background, I even still remember. You mentioned that the juniors provide. You guys, you are the service providers. You are the guys to do 40 C-sections in a month. You are the guys to do hysterectomies. When you talk of juniors in Augo, the junior is most of our associates, yes? And then the medical officer special grade. You are the providers. You are the ones to run the theater lists. You're the ones to run the clinics, the heaviest, by the way. Now, if you are in a private and you are the provider, get your money. Because I'm very sure in most of up-to-date functional private facilities, you're paid by output. No serious provider, administrator will give you a salary. You will make it. And I tell, Rogers is one of them, I tell them that they are my employers. As a medical director, if I don't have them, I have no money. I don't employ consultants. They come to the facility to employ me. Because when a surgeon does an endoscopy and does it very nicely, I earn something, isn't it? So he is my employer. Now, in between providers, on top there are insurers. The insurers are the VC, DVCs, head of department, hospital directors, senior consultant there, who ensure that the standards are okay for us to grow, to be mentored, to provide the services. The guidelines are in place and all that. In between there are assurers, people who look at these things over and over again, validate the guidelines, ensure that everything is in order. And then between the assurers and the providers are the supervisors, the consultants, they are in between there. Above there, heads, the assurers are the senior consultants, and that stuck into my mind. If you look at that stratification, you must honorably take the position that you are in and start striving to reach the next position, other than wanting to call what we call jumping the queue. The only problem that we have, some of those things are not, things are not well streamlined. Sometimes you think you should be there when you're not. And that takes me to a little bit of description of what happens, the cadres in MOH. Our associates, your students, then medical officer special grade. I think one is supposed to serve as a medical special grade, medical officers, for 3 years, 6 years. It's not a short time. So if you're there, but in the 6 years, please get your fellowship, get your training, get your everything, so that when you are let off to go, you have what it takes. I remember my first analogy, you will not get a lift when you are in a footpath. Okay? Of course, there are consultants. How many years do you stay as a consultant before you get to senior consultant? Another 6 years. Okay? And then from there you got senior consultant. I think he's with others struggling to change that structure. To put a chief medical officer and a chief consultant and things like that. In the university section, our associates are likely to be teaching assistants. You're likely to be assistant lecturers and lecturers, because there is an amendment for MBCHB, you can become a lecturer in certain institutions with a waiver. But I doubt if it still works in Makerere. In Makerere, to become a lecturer, you must have a PhD because they have enough. So their footpath is very short. You must do your part. So basically, to become a lecturer, you should have a PhD. Then, when you become a lecturer, to transition from lecturer to senior lecturer, minimum is 5 years plus other requirements. From senior lecturer to associate professor, another 5 years. Associate professor to professor, another 5 years. This is duration plus other things, publications, research grants, how many students have you taught? So it is not a simple journey. Don't just look at it and say, I am going to jump there. But be ready when the time comes. Now, I want us to recognize some notable, important obstetrician gynecologists who are becoming seniors in even areas which are not routinely our area. The DVC of KIU, Professor Frank Kaharuza, is in things. You get a DVC who is an obstetrician. I think the deans, I don't want to mention Ngonzi, Maxwell is here, the deans of medical schools. I think there is one, Dr. Mutiava, in Ayo. And so in medical schools currently, the trend is the deans to become obstetricians and gynecologists. We have the executive director of Makerere Hospital. Imagine all professionals, Dr. Joseph Atbiamjisha. So we have notable people in places where competition would be high, but because they have got out of the footpath, the journey is just beginning. Finally, I want to talk about this book. On my titles, I've been added a book writer, and I've donated a copy to Augu Library. The president will take it to himself, to the library. And the book is challenging. I think, Dr. Dan, you mentioned there is no textbook with COVID as a chapter. That statement is in the history because there is a chapter on COVID in here, COVID in pregnancy. And by that, I will ask you to auction one copy here at another opportunity, not today, but I'm sure you'll go with a copy. For you, I think the copy should be at 1 million because you know what books are. It has also another chapter or area in intrapartum care that is about the labor care guide. Juniors, if your seniors have been tormenting you over the pathogram, it is your chance now to go and tell them, take your pathogram to hell, because we are now in the labor care guide era. But you're not going to do it if you have not known how to use the labor care guide. So there is a labor care guide, a write-up. There is also medical simulation as a means of educating health scientists, health professionals.
Our uncle, the elder, I think you should be very proud right now. Let us clap for Dr. Mjenyi. That was not nice. Let us make an organized one. You will only understand the significance of this command from me for you to clap your hands for him when you come in position of leadership. You will only understand that you are wrong, or you were wrong at some point when some people are complaining that you are wrong because they are wrong and you are trying to implement the right things. Are we together? It will come to pass. So for people who have walked through his hands, me inclusive, We owe you apologies, but importantly, want to say, I think I agree that we should give maximum respect to our seniors. I agree to this because he was saying they are able to see what we can't see. But we need to stand on their shoulders to see what they are seeing while seated. Some of us are able to see what we could not see when they were forcing us to see. So I think continue doing the good job, Dr. Mjenyi. As the blessings are yours. I think all this said, Dr. Henry had said I should use 2 minutes because he's hungry. I think I have taken close to 3 minutes. And yes, my OG is reminding me something about Kitagwenda, where she comes from. We shall deal with that later on. But I think in the spirit of oneness, I wouldn't want to make a conclusion when I don't really sound a very strong decision to Professor Kaye. Professor Kaye, let's put our hands together for him before I say what I want to say. He deserves it, so I'm not going to tell you why I made you to do that. He deserves that. He's here with us. He has mentored us in one way or the other. We give you allegiance. We pay our allegiance to our seniors. An institution where there is no discipline is a dead institution, true or false? I'm saying it, an institution where there is no discipline is a dead institution, true or false? Yeah, so we pay allegiance to our mentors. Dr. Kaye, Professor Kaye, sorry, you deserve more than what we can say, but I think paying allegiance to you, the seniors, mean a lot to me when I mention that. That said, I want to say I conclude my submission this afternoon, this evening, and I wish you the very best. Let's stay together. Let's remember the cooperative emblems. Let us respect the newly elected leaders. Let us support and rally our forces, our troops behind Augo. And that said, I say bye for now, and I submit. I hand over the microphone to Dr. Rogers. Thank you very much.
Thank you, Dean Maxwell. The meeting has we've come to the end of the meeting. Just 3 announcements. One is plain announcement. The others are administrative. The announcement is that in Chisi's Hospital, there will be the laparoscopy camp starting on 1st August, which will run for a week, and then thereafter they will be doing surgeries routinely. So if you have a patient or you want to be a part of it, you can speak to Dr. Lukawe Henry to get more information. 2, we shall have a group photo as we move to the lunch place, I think just outside here. Our lunch will be served up there in the restaurant. And then 3, for those of us who came from outside in Mbarara, the association, secretariat in particular, managed to get a very small transport refund. And really small is the main word in the statement. But please take it with the heart of appreciation, knowing where we are coming from. Those are the announcements. Dr. Fiona is there. Please remember to those who wish to subscribe. She's already, I think she's told me some people have already done it. Don't worry about the receipting. We shall follow up and make sure, see to it that the money is accounted for. Thank you very much. Thank you, BSV, for sponsoring this. Thank you, Professor Kaye and Dr. Musana, for coming to join us. Thank you, our members from within and outside Mbarara. We hope to do this more and more. And please have a safe trip when you're traveling back. Oh, and we thank ETV, which has covered this live. It is also recorded. It's been live on YouTube, so there will be a video to watch if, in case you want to view the content once more.
check 1 2 check 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 1 2 check mic check 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 1 2 check 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 1 2 1 2 check 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 1 2 1 1 check 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 1 2 check 1 1 check 2 2 2 2 check check 1 2 check 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 1 2 check 1 2 mama wabo tagambire 1 2 tubikora niyo pattern check 1 2 check mic check